Asha? एक ये ब्रेकफास्ट
My husband's also Dr. Srinivas anesthesia.
No.
He is the director of Mallige Smile Foundation and a member of Hyderabad Cleft Society. Sir is also a Senate member of Rajiv Gandhi University of Health Sciences, and he is faculty to train postgraduates to the government of Bangladesh, government of Ethiopia and Romania.
Welcome to each one of you to this prestigious conference on maxillofacial surgery, the present and the future. We are gathered here today to embark on a journey of exploration and discovery into the fascinating world of maxillofacial surgery, where we all delve into both the remarkable advancements of the present and the exciting possibilities that await us in the future. Maxillofacial surgery at the intersection of medicine and dentistry has undergone remarkable transformation over the years. From its early days of basic procedures to the cutting-edge techniques and technologies available today, the field has continuously evolved, restoring function, improving aesthetics, and positively impacting the lives of countless patients. In this conference, we have brought together leading experts, pioneers, and researchers from around the world who have contributed significantly to this domain. Through their expertise and dedication, we have made incredible strides in addressing complex facial traumas, congenital deformities, oncological challenges, and various other conditions affecting the patients. Let's make this conference a resounding success and a stepping stone towards a more advanced and compassionate approach to maxillofacial surgery. With this, to commence the conference, I would like to request the chairpersons to come up on the stage for the first speaker. I would request Dr. Zakaullah sir, Principal, Al-Badr Dental College and Professor, Department of Oromaxillofacial Surgery, Al-Badr Dental College, and Dr. Aqib Hashmi sir, Assistant Professor, Department of Oromaxillofacial Surgery, HKE Dental College, to please come up on the stage. A big round of applause. Speaker for the event, I would like to request Dr. Vikhar Ahmed sir, Associate Professor, Department of Dentistry, Faculty of Medical Sciences, KBN TGH, to please come up on the stage.
Morning everyone. It gives me immense pleasure to introduce Dr. Nagarajappa Das sir. He is Professor and HOD of OMFS SGM Dental College and Hospital Chitradurga. He completed his MDS from SGM Dental College, Dharwad in 2005. He is presently Honorable Secretary of Karnataka State Chapter Oral Maxillofacial Surgery, and he is accuracy coordinator. He has more than 18 years of experience in academic and clinical work in various areas of oral surgery. Sir has been a keynote speaker for Ramchandra University, Chennai, and a speaker in masterclass in MSI. Sir has various publications in national and international journals to his credit, and has presented various papers in conferences. Sir is also a reviewer for national and international journals. Sir has specially trained in AOCNF, TMJ arthroscopy, and total joint replacement. Sir area of interest is maxillofacial trauma, TMJ, cyst and tumors, and dental implants. I now welcome Sir onto the dais.
A very good morning to you all, and my very good morning, respected chairperson and my dear friend Zaka and sir. And I thank the prestigious University Khaja Bandanawaz University and Department of Dentistry and Professor Ali for giving me this opportunity to speak on this continued professional development program at this university. So, if I stand here, I remember my UG days. I did my undergraduate from Gulbarga University, from Umnabad Dental College, where Khaja Bandanawaz Hospital was one of the known hospitals in this territory. I was 25 years back. I was a part. They conducted massive health camp in Ahmedabad. So I was a volunteer for that camp. After that, I'm standing here as a speaker in this prestigious university. Once again, thank all the management and organizing committee of Khaja Bandanawaz University and Hospital. So thank you. So today I will be talking on a topic called scope and limitations of oral and maxillofacial surgery. In my presentation, I will be stressing on every areas of oral and maxillofacial surgery. The in-depth will be taken discussion and presentation by my esteemed speakers, senior speakers in later lectures. Coming to the, I'll be talking on this content. What is OMFS? Evolution of oral and maxillofacial surgery. What will we do in this specialty? And what are the recent advances in each areas of maxillofacial surgery? What are the training pathways of maxillofacial surgery across the globe? And the concluding part. By definition, the oral and maxillofacial surgery, is a three-component: oral, a maxillo, and facial. Oral means mouth, a maxillo means jaw, and facial means a face. So, it's a branch is one of the specialty in dentistry that includes diagnosis, surgical, adjuvant treatment of diseases, injuries, and the defect, including both a functional and aesthetic aspect of hard and soft tissues of the oral and maxillofacial surgery. The aim of this course is covers both the medical and surgical management of the diseases and disorders affecting the orofacial region. The teaching program of this specialty has got wide range of non-surgical procedures, stressing the need of both the dental and medical knowledge when you treat these areas. So, of course, the pain and accident management with the local anesthesia as well as general anesthesia, the basic oral surgery element and the maxillofacial element. So, once upon a time, it was only an oral surgical element. So, where it is restricted to removal of a teeth or some minor surgery related to the mouth or oral cavity. Now, it has taken up in such a way that the maxillofacial and the craniofacial, correcting the craniofacial syndromes, all those things. We will be discussing in the further slides. These surgical procedures in this specialty includes starting from a simple tooth removal or extraction to reconstructing the complex facial or craniofacial skeleton. Coming to the history says that way back 460 BC, the Hippocrates is the one he has reported a case of where a mandibular condyle dislocation. So that shows us, that indicate that there is a long history for this specialty. After the Second World War, basically, a lot of casualties in and around the facial skeleton or the cranial or maxillofacial region. So then everybody thought that there should be some specialty related to maxillofacial region. Thereafter, the specialty has grown into oral and maxillofacial surgery across the globe. Oral and maxillofacial surgery is an evolving field. Evolvement of new techniques has widened the scope of OMFS. Today, the scope of OMS practice continues to expand as a result of educational process that is responsive to the changing needs of the specialty. The recent advances and the technology is finding promising scope in this field. The scope, when we talk about, so there are certain areas of maxillofacial surgery, from basic like oral surgical component to the till the hair transplant, correction of craniofacial deformities, and so on. The recent advances like going for minimal invasive surgeries, then scopies, then applying technology, digitalization, then 3D printing, then joint replacement, of course microvascular surgery for reconstruction of the facial deformities, and robotic surgeries. All these are the recent trends or recent advances in the field of OMFS. So when you operate or when you think of facial maxillary region, you should think of the anatomy of the face. It's a complex structure. It involves most of the vital structures, parotid, facial nerve, and the function of the face you should know. So when you're treating this kind of face, when you're examining this case of patient, one should think and remember this, the function and the anatomical structure of pertaining to facial region. So now I will be stressing on, briefly about each areas of maxillofacial surgery. So to begin with, so dental surgery. So dental name itself, dental and alveolar component. So the treatment or surgical procedure will be pertaining to that. So basically the common is extractions, then wisdom tooth surgery, dental implants, then endodontic surgery. So this is the evolution of how the forceps and extraction taken place over the years. So we was there and we were standing here, elevators and forceps. Now we talk about physics and forceps. So these are atraumatic forceps. This is what the recent advances in extraction or exodontia. The impacted teeth is the teeth where, is completely or partially unerupted teeth in the oral cavity. This is the commonest oral surgical or minor surgical procedures performed by any maxillofacial surgeons under local anesthesia. If the patient is allergic, we will do it under general anesthesia. So this is the one. And here the advantage, the recent trends, like we used to depend on once upon a time only on a small intraoral periapical films where we will take it in a dental clinic. Now, after later that we got OPG, orthopentagram to know the tooth position, angulation and depth of impaction. So now at this era, we got something called SCBCT where we can know the relation of the inferior alveolar nerve with this thing, depth of the impaction, the root pattern, and all the angulations related to the impacted teeth, any teeth for that matter. For most commonly, the mandibular third molar will get impacted. So after this, there was a time where we used to use a chisel mallet to remove of these teeth and forceps and micromotor and handpiece. Now we are in the era where we apply a physiosurgery. So a physiosurgery is a very precise one. So to remove the bone in and around the teeth, so less post-operative complications will be there. So this is a recent trend in this exodontia. Sorry. Coming to dental implants, again, the implants are nothing but replacement of the teeth which is lost. So that is called as prosthetic rehabilitation. There were a time where people used to, general dentistry, crown and braids. Now we have called as implantology. So here is a case, is again an advantage of the recent advances in this. We have called navigation surgery. So what you call as virtual planning. So virtual planning is that we can plan what type of implant we can place, what is the diameter, what are the length of the implant. So this is really a boon when you're planning implants. So again, we have here zygomatic implants, then we have then basal implants or cortical implants. So these are the recent trends in this dental implant area. Another one is maxillary sinus pathology. This is an area where even ENT surgeons and does this sinus surgeries and other things. But one incident we'll commonly encounter in maxillofacial, that is, when you're extracting maxillary molars and all, it is very close to the maxillary sinus. So if there is a traumatic extraction, there may be something called as oral-enteral communication. If it is unnoticed, then later it goes to called a fistula. So this can be treated or managed by surgical advancement flaps, buccal and palatal flaps. So thereby we can treat this thing. So this is also one of the. Another one, the area is maxillofacial trauma or injuries. So this is the most of the maxillofacial surgeons perform these procedures like trauma. Since the more incidents of RTS in our country, so we have a lot of cases where with the invent of the plating system available at this present scenario, so the maxillofacial trauma management has taken in a different era. So after the basic emergency management, so that whatever the fracture, it will be managed like how we manage generally reduction, fixation and immobilization. We have fixation methodology, various methods are there. There was a time there was no fixation methodology. We used to go for a close reduction where it was splinting and locking jaw for 4 to 5 weeks or 1.5 months. Now we are not doing that. We have so-called sophisticated plating systems are available, resorbable plating system available. We have a 3D print. We have virtual planning. We have minimal invasive endoscopic approaches for condyle and zygomatic and orbit. And we have something called as today we speak about patient-specific implant. So this gives a more precise and more anatomical reduction and fixation for managing a craniofacial trauma injuries. So these are few cases where it is managed, how it is managed. This is a fan facial fracture, dental fractures, and midface fracture where intraoral approach you can do, and we can go with the titanium plates. And this is the technique, old technique where we used to put an arch bar and fix the jaw for 1.5 months so. This is a case of orbital fracture where we have used the technology, 3D printing. We can assess, the advantage of 3D printing is that you can assess the defect, we can pre-plan, we can, before surgery, we can plan how it will be the outcome of the surgery, and also you can better explain to the patient regarding what has happened and how it will be dealt. And of course, the orbital floor fracture also can be managed with orbital mesh. And zygomatic complex fracture again is one of the commonest facial bone fractures where we can approach infraorbital FZ and all. And another one is the lower 1/3 of the face that is made up of mandible. So this is one of the strongest bone in the facial skeleton. It gives attachment to the various muscles of the face and forms articulation with the glenoid fossa called as temporomandibular joint. And it basically provides a normal airway and contour to the face. So these fractures also will be dealt. There was a time where we used to do only close reduction. Now, because of the availability of the newer plating system, various design, these are cases, a few example for various type of mandibular fracture. This is another case where condylar fracture with minimal approach by extraoral, taking care of vital structure like marginal mandibular nerve, parotid, and facial nerve branch. So you can go for various plating system like delta, 3D plating we call it as. Instead of conventional, we can go for delta, lambda, and all, depending upon the case or scenario. And coming to the recent advances in this maxillofacial trauma, you can make out here, there are various plating designs are available and various systems are available. So here you can see that there is a resorbable plates, there are matrix system, which is OCM. We have what we call as intramaxillary fixation screws, then patient-specific implants. Again, here the defect of the maxillofacial skeleton or craniofacial skeleton can be done with a patient-specific implant using a PEEK material. And this is how you go for a minimal invasive endoscopic approach. So selecting that, you can think of, you can avoid extraoral scarring and incision will be minimal. Coming to temporomandibular joint, it is the only joint we dealt in the craniofacial region, that is temporomandibular joint. So there are two components, one is a glenoid fossa, another one is a mandibular component. This is a very small joint, but there are diseases pertaining to this TMJ dislocation, TMJ ankylosis, TMD, and temporomandibular joint arthroscopy, and total joint replacement. So here is the case where TMJ dislocation or mandibular condyle dislocation, we had the manual reduction followed by barrel bandage. And these are the things we routinely do it in day-to-day practice. And another one is called as TMD disorder. There was a time where we used to call it as MPDS. Now it has changed into temporomandibular disorders. So this can be treated conservatively or surgically. So conservatively, we will have splints, soft splints and hard splints like that, occlusal splints. Thereby, we will treat those temporomandibular pain. So this is a case where temporomandibular bilateral TMJ ankylosis. Because of the trauma, both the joints are fused and there will not be any growth of the mandible. Mandible will be hypoplastic. And in these cases, nowadays, what we have a 3D printing, we can plan and you can apply, you can think of joint replacement, or you can think of correcting the lower jaw deformity like selecting orthognathic procedures and distraction osteogenesis. All these things are possible advances in this specialty. And coming to the recent advances in this temporomandibular joint, so arthrosynthesis is nothing but is joint lavage where a painful joint patient comes. We can do a joint lavage, that is arthrosynthesis. We have so-called as arthroscopy to as a diagnostic as well as a therapeutic way. And we have something called as total joint replacement. So the entire joint can be replaced depending upon the indications. So there we have two components. One is the glenoid fossa component and the mandibular component. So this is how the pre-operatively planned, and it will be executed on the patient. There are two types, custom made and patient-specific implants. So this topic will be dealt by my senior speaker in the next presentation, I think. So I don't want to stress more on that, just I'm outlining what are the recent advances in this section. Coming to the cyst of the jaw, this is one of the, again, commonest procedure performed by maxillofacial surgeon from olden days. So it's a pathological cavity in the maxilla or mandible. So we have two types, odontogenic and non-odontogenic. Means it originating from the dental forming cells, where non-odontogenic is a fissural or developmental cyst. Same way, there are tumors called odontogenic tumors and non-odontogenic tumors. So those are benign tumors. So these are few examples for cystic lesions. Usually we do simple procedure like surgical enucleation or something called as Maxillofacial, or you can resection of the mandibular maxilla can be done, followed by you can reconstruct with microvascular, or nowadays a patient-specific implant have come. So a lot of things are there to reconstruct and rehabilitate that particular patients. Here is another case where there is a cystic lesion in the mandibular anterior. So we have made a 3D print. So by doing the 3D print, you can see the extent of the lesion and also the defect, and also you can better explain to the patient what has happened, how it is, and later you can think of going for patient-specific implant for recountering and reshaping the defect. Again, coming to the benign tumors, is again odontogenic, non-odontogenic. One of the commonest benign tumor is ameloblastoma. So again, ameloblastoma can be managed either surgically or resection, en-bloc resection, followed by reconstruction. And this is the one case where it is diagnosed for, unfortunately, the patient didn't turn up for surgery, but they walked into clinic like this in our OPD, where we did biopsy and turned out to be a huge ameloblastoma, where the entire mandible was involved with the lesion. So the ameloblastoma may be so aggressive. It may be a small one with very huge mass. Coming to cellular gland pathology, again we are here, we deal with, deal with ranulas, silolith, that is a stone, and parotid tumors involving the major and minor salivary gland. Here is a few cases where mucocil, then silolith, and the pleomorphic adenoma of the hard palate, minor salivary gland. And the recent advances in this salivary gland is a minimal invasive surgery, like how the scopies are there, silendoscopy. So we have silendoscopy dilators. By this, we can use diagnostic or therapeutic purpose for salivary gland disorders. Maybe stone removal, then stitcher, then chronic inflammation of the joint and other thing. So coming to the other one is the areas orofacial space infections or odontogenic or facial space infection. So in dental caries, if it is not treated at the earliest, it goes for dental abscess. If it is not, depending upon the host mechanism, it may go to the neighboring spaces. There are a lot of potential spaces exist in the adenic region. So this is a case where it's involved a temporal space, the buccal space, and submandibular space. So extraction of the offending teeth and followed by incision and drainage of the particular space. If you do, then it will be that is a procedure will be employed in case of orofacial space infections. Of course, so ultrasonography will help you what space are involved and what all the involvement of the space nowadays. So that is the one recent applicability in diagnosing and managing odontogenic space infections. So here is the case where bacterial osteomyelitis of the mandible, where we have done resection of the mandible, which is a disease or osteomyelitis, and the recon plate is placed. And as we all aware, during the second wave of COVID, so where most of the facial skeleton, especially maxilla and orbit and mandible, very few mandible have cases reported, but most of the cases are maxilla. So they all turned up into like fungal osteomyelitis, so-called mycorrhizasis or a black fungus. This really a challenge for medical fraternity as well as our specialty to handle these cases. So after the resection, a patient used to walk into the mobility of the teeth. But when you see CT scan, MRI and all, things were different. So where we are able to, resect all of the maxilla, orbital extension, all those things. So what we'll do after resection, after, defect, what we'll do? So there is a solution we got, that is a patient-specific implants. So you design later, computer designing, then with the help of prosthodontics or anything, occlusal, this thing, then we can rehabilitate them with the patient-specific implant. The entire craniofacial skeleton can be replaced with that. Now the other area is orthognathic surgery. This is one of the most fascinating and commonly employed by our specialty. So it's a facial plastic surgery combined with orthodontic to correct the jaw deformities. Like somebody will have prognathic mandible, somebody will have retrognathic mandible, somebody will have maxilla forwardly placed, somebody will have hypoplastic maxilla, especially in a cleft lip and palate patient. So in those patients, of course, the orthognathic procedures and post-TMJ ankylosis patient and other facial deformities, the orthognathic surgery gives them a better appearance, better function and all. So here orthodontist plays an important role aligning the teeth, and the jaw discrepancy will be done, carried out by doing for the various osteotomies. Again, this area will be stressed by another senior faculty in the coming lectures. Again, in the orthognathic, there are a lot of recent advances like virtual planning, 3D printing, then physiosurgery and mock surgery. So there was a time where we have to lateral cephalometry. We used to take landmark, make a cast and splint like that. Now we have software where incorporate all these landmarks and make a pre-operatively you can design the cuts of osteotomy cuts. You can prepare interim splits and spinal splint according to this thing, and we can computerized program. We can do a better planning for orthognathic surgery. And of course, you can use a 3D print. And there is, as I said, physiosurgery is a very precise one. It's very good to cut the bone, and there will be less trauma to the bone. So the physiosurgery applications in the orthognathic again boost up the osteotomy procedures. Another one is cleft lip and palate, is a congenital deformities. Again, management of these cases are very challenging, and it needs a multidisciplinary approach. As we know, the cleft lip palate takes series of surgeries. Lip, palate by palate, then alveografting, then rhinoplasty, then orthognathic, then distraction, and so on and so. So that means you need a multidisciplinary, and you have to follow up this patient. So here is the few cases where unilateral cleft lip and palate. And another one is a craniofacial surgery. This is a new emerging trend in our specialty. Few of them trained in this, the managing, craniofacial syndromes and other skull deformities like brachycephaly, telecephaly and all. Craniosynostosis. Again here, you can plan virtually and you can do a model. After that, we can perform something with the help of a pediatric neurosurgeon to fix this, skull bones. Distraction analysis is the one, again, this was an old entity, and this technique deals with elongation of the bone, gradual callus election. This needs, these applied corrections of facial deformities, craniofacial syndrome, and facial deformities. I'll take another 10 minutes. Coming to the academic oncology, so again, a surgical oncology is one area where many have do a fellowship and execute, the reconstructions of the, defect with either conventional flaps and microvascular reconstruction. Again, sometimes it needs multidisciplinary approach. There are many of our faculty OMFS, they're doing exclusively, academic oncology and reconstruction. There are a few cases to show. And we have reconstruction surgery, we have conventional flap like local flaps, distant flap like buccal fat of fat, nasolabial, all those flap, and distant pectoralis major, which is commonly employed to cover the defect of the oral cavity. And microvascular, we have commonly used radial form for soft tissue, and hard tissue, you can osteocutaneous is a fibula free flaps. And this is a microvascular setup. We have fellowship around the country. Various centers are there where they'll train how to anastomose, how to do vein-to-vein anastomosis, artery, all those things. And again, the craniofacial pain, facial pain disorder also part of our specialty, where trigeminal neuralgia, atypical facial pain, TMD disorder, which I was mentioning earlier. So all those things will be dealt in our specialty. And Special aesthetic surgery, we have so many things like Botox, rhinoplasty, then scar revision, then laser, then physiosurgery, then recently hair transplantation. So all these things can be done under a facial or a OMFS specialty. And this is a case where we have done chilioplasty, and this is where a mold removal. Using RF Cautery, we can use laser, we can use conventional surgery to correct these facial deformities. Now, coming to the what is the approaches training in OMFS. Whereas in other countries, so we have 4 to 6 years residency program, 4 years program, only the certificate will be entitled. If a 6-year residency program, they will have dual degree, medical and the maxillofacial in first world country, so called. In India, we have a 5 years BDS course, followed by 3 years MDS course. And of course, during that time, they will expose all this spectrum of OMFS. Later, they pursue their interest, whichever area they are keen. Oncology, we have a fellowship by Rajiv Gandhi University of Health Sciences. Other various deemed universities fellowships are available, craniofacial deformity and all. From our association, we have fellowship pertaining to the orthognathic surgery and the craniofacial deformities, again head oncology where and orthognathic where they have more work. Those centers will be recognized from our association, and they will those who freshly passed out to enhance, to improve their skills in particular area of OMFS, they can opt that. And few literature to show, what is the awareness about our specialty. Okay, so overall maxillofacial surgery, a specialty altered by time and circumstances. Public and professional perception about our specialty. There was a pilot study. Awareness about oral maxillofacial surgery among general public in British Journal. 2 minutes over. Are people aware of oral maxillofacial surgery in India? Training pathways in oral maxillofacial across the globe. A mini review is there, you can go through. To conclude today's my talk, oral maxillofacial surgery has emerged as a specialized branch of dentistry over the course of time and has opened up new options in the field of surgery beyond basic dentistry. The field of OMFS is constantly evolving, adopting newer techniques to refine the surgical procedures. It is extremely difficult to outline the scope of specialty, update with the new literature, recent advances, technology on this specialty. So I end my topic by saying, as goes your technology and your skills, so goes your practice, give the opportunity marks. So thank you, Anand, for patience hearing. So once again, I'll thank the organizing team for giving me this wonderful opportunity to speak on our specialty. I thank all our members also and chairpersons for giving me this opportunity. Thank you, Anand.
It's a really very well given a overall view of oral and maxillofacial surgery branch and its scope. Hope we have covered, I hope everything has been covered. So it is really very beneficial. Most of the postgraduate students are also here, and the interns, or a lot of interns are also registered. So they have understood what is the scope of oral and maxillofacial surgery as a branch, because it is one of the emerging field in the current days, because as the days are advances, the various technologies have incorporated, which is beneficial for the as the oral and maxillofacial surgeons. So thank you for your presentation. It is a wonderful presentation. Overall thing has been incorporated in your presentation. If further any doubts are there, so this floor is open to ask the question if any person is having any doubt. Senior faculty members are also here, and then most of the medical fraternity is also there, and PGs and interns are there. If any doubts are there, this floor is open for about 2 minutes to ask for the questions.
Are welcome. We'll hold for more 10 seconds for the question to come, and we'll move on. Okay. Thank you so much, sir. Now to move on, I would like to request the chairpersons to please felicitate Dr. Nagarajappa Das, sir. I'd like to request the volunteer to please escort the speaker to his seat. Thank you, sir. Next, Dr. M.A. Basir, sir, Director IQAC KBN University, and also the Professor in HOD of Community Medicine to felicitate the chairpersons. Thank you, sir. We'll begin the next talk in 2 minutes. Moving on to the next lecture, I would like to invite on stage the chairpersons, Dr. Ravindra Devni, sir, Professor, Department of Surgery, Faculty of Medical Sciences, KBN University, and Dr. Syed Mushtaq Hashmi, sir, Professor in HOD, Department of ENT, Faculty of Medical Sciences, KBN University. And to introduce our next speaker, I would like to request Dr. Aisha Fatima ma'am, Senior Resident, Department of Dentistry, Faculty of Medical Sciences, KBN TGH, to please come up on the stage.
Thank you, Dr. Irfan. Good morning, everyone. It gives me immense pleasure to introduce Dr. Urpi Krishna Joshi, Professor and HOD, Department of Oral Maxillofacial Surgery, HK's S. Nijlingappa Institute of Dental Science, Kalburgi. A pioneer in the practice of oral surgery at Kalburgi, he has completed his BDS from HK and MDS from Mangalore University. Sir has completed his MOS RCS from Edinburgh, UK. And Sir is also a law graduate from Gulbarga University. Sir has done more than 25 publications, international and national journals to his credit. Sir has attended various international and national conferences as a resource faculty. Sir is teaching postgraduates and undergraduates since 19 years. Sir has presented many scientific deliberations at International Conference of Oral Maxillofacial Surgery at Barcelona, Spain, Melbourne, Australia, and Hong Kong. Sir has also chaired many scientific sessions. His area of interest is trauma and aesthetic facial surgery. With over 18 years of experience, he currently handles patients in his area of interest, trauma and aesthetic facial surgery. Sir's clinical outcome has been excellent, with complex cases being resolved. I now welcome Sir onto the stage. Welcome, Sir.
Thank you so much for such a gracious introduction. At the outset, I would like to thank the organizing committee of KBN University and the management of KBN University for giving me an opportunity to share my views on this August platform. I sincerely thank Dr. Ali, who has taken a lot of pains and he was involved in arranging all the talks and all. Now, in the introduction, have been already explained that what I have achieved in this area. I have done my BDS from this, the first batch from HK's Dental College in 1990. After that, I got my MDS from A.B. Shetty Institute of Medical Sciences, Mangalore. Then, after that, I have dedicated my services to this area, that is this Gulbarga and surrounding places. When I came to Gulbarga, I was finding it so amazing that none of the maxillofacial injuries were attended by the maxillofacial surgeons surrounding also. People used to run to Hyderabad, they used to go to Sholapur for getting their treatment. Now, the present scenario is any type of maxillofacial lesions or even trauma, everything can be addressed in this place. That is due to the involvement of the colleges which have come up, that is HK College, Al-Badr College, ESI College, and then the medical colleges which have come up. So I am now the part of the teaching faculty in HK's Dental College, and I'm working for the United Hospitals, which is a prestige hospital in Gulbarga. Next slide, please. I will be speaking on management of the complicated midface fractures. Since I've involved more in trauma, that is management of the fractures of the maxillofacial region, I would like to talk more about the trauma. The facial skeleton, this is a simple thing which I think everyone knows, which is divided into upper, middle, and lower third. Maxillofacial as such, the upper one-third, which becomes a part of cranium, is addressed very little. When it comes to the part of naso-orbital region, the maxillofacial surgeons have a role. Above that and all will be most of the times handled by the neurosurgeons. The next slide, please. To know the anatomy, I think everyone who has done the medicine and the dentistry will be aware that a lot of paired and unpaired bones which are there, which has a significance. Why I have put this slide is, without the knowledge of these bones, the management of the midface trauma, which is very, very complicated. Imagine these bones are not linear bones. They are all curved bones, and then they are all small bones. They need to be addressed in the trauma. So, okay. So these are the bones which you need to know. I will tell you the significance of this. You will understand when I show one of my cases where the anatomical knowledge is required very much. This is the biomechanics. See, if you see that, the trauma whenever happens, we all know that when someone falls or when any trauma happens, most of the time it is the mandible which is getting hit. And the cranium, to get support, the forces not to reach the cranial base, the maxilla will be acting as a barrier in between. So but what happens is, when there is a trauma to mandible, the load before going to cranial base will fracture the midface. That includes all the bones which I have told. The very important aspect in the management of the midface fractures includes the knowledge about the buttresses. You know that whenever the main treatment would be the reduction and fixation. Reduction as such will be to unite the bones. But then when we fix, we need to have a stable bone. So the skull has got different buttresses. Buttresses in the sense, they are all the thicker bones in the regions in the skull. We have vertical buttresses. There are three. That is nasomaxillary, pterygomaxillary, and zygomaticomaxillary buttresses. And five horizontal buttresses. But three are in the midface. Now these are important to manage the midface trauma. Most of the times the etiology would be the road traffic accidents. Now you all know the velocity with which the vehicles move. So that will lead to the more grievous injuries to the maxillofacial region. The assault and other causes also include the reason for as a etiology for the midface fractures. Now, most of us know how the classification has evolved for the midface fractures. We all know Lefort 1, 2, 3 and modified Lefort fractures. These are all the lines which have been explained in the book. But I think none of the maxillofacial surgeons who are operating will find exacting the Lefort 1 line or Lefort 2 line or Lefort 3 lines. However, this is very significant because the statistics have proved that when the trauma happens to the dentoalveolar region, that becomes Lefort 1 line because it's a weaker line in the midface. However, the trauma which is occurring with the velocity of the accidents, they are going to give a different picture. I'm going to show you my experience of last 25 years. These are the other classification, that is zygomatico complex, and then we have orbital fractures and naso-orbito-ethmoidal fractures. Now, when these fractures are to be addressed, the most important aspect everyone should know is the emergency management. If there is a fracture we know which is evident as a fracture in the midface or the mandible or maxillofacial region, the emergency treatment, which includes all of us know it is ABCs of the management of trauma. All those will have to be dealt first. Only then we can go for the management of fracture. We need to do that the very vital structures like orbit containing all the eyeball and all structures, contents of the orbit, and we have nose and the sinus. All these structures are present in the midface. These needs to be examined properly. The ear also being involved in the midface many a times, we need to even examine the ear. Other associated injuries, of course, will be examined prior as a general examination. That is, we need to know any brain injuries are there, spinal, which is very significant, because before giving the anesthesia, we know that nowadays when we talk about the primary management, we first speak about the airway along with the cervical spine. We need to see the airway. At the same time, we are going to stabilize or thinking that any trauma, unless excluded, is having the cervical spine injury. Keeping that in mind, we always see that we address the cervical spine also in the initial examination. If you see what I have showed just now, the slides of Lefort 1, 2 and all, none of them will suit this. These are the cases which have been operated. Only the mid one will show you the Lefort 2 line, slightly matching. See the slide on the right side. We cannot have any particular classification for that. It is totally comminuted. You can see one part of the maxilla moved high, up, orbit is gone, all the nasal bones have gone, the mandible is fractured, all the bones in the midface have been fractured. These needs to be addressed patient specific. We cannot expect Lefort line to be like that and all. Now, how do we come across and how we deal with this, and my experience of dealing such variety cases, I would like to share in this platform. Now, the management of midface fractures are very complex and challenging. The reason being, I've told you, there are a lot of bones, paired and unpaired bones. One of the very important principles, what is being taught in orthopedics or the maxillofacial surgery, is good, beautiful anatomic reduction is required. But at the same time, that is not the only thing. A beautiful reduction of mandible, but the patient is unable to chew or masticate. That is not the management. We need to think about how the patient is going to have the function. Along with the aesthetics functions, we can go for the anatomical reduction. This requires a clear understanding of the facial buttress system, which I have already told the significance of it. Nowadays, we have got the 3D imaging. Just now, Dr. Nagaraj has told how 3D imaging has helped the maxillofacial surgery, trauma, or any field for that matter. So what we can do is we can take the CT scan and send it to a lab where they will fabricate the required plating system or the patient specific plates, and accordingly we can manage. There are different approaches to go to the midface. Most of the time, what approach we try to use is we try to avoid scarring of the face. So most of the time, whenever it is possible, it is through the intraoral route we operate. And whenever we need to expose extraoral, we will try to hide the scar as much as possible. For example, we have subconjunctival approach to approach the floor of the orbit, where the scar is very, very minimal, that is not visible also. Now, one of the very important aspects in management of midface would be, all of us know that when we manage the trauma, we need to get a function post-operative. The function of the oral cavity, basically the most important would be the mastication and chewing, for which we need to keep the occlusion and do the fixation. Now, since the maxilla is fractured, shattered, and nasal bone is also fractured, we cannot intubate the patient through the nasal nose. That is, nasal intubation is usually not possible because of the fractured bones. Now, the anesthetist, if you put the tube orally, then to get the occlusion would be very difficult. So what we do is, we have other options. The very long time what was followed was the tracheostomy. But we all know how the tracheostomy will be debilitating the patient. So we have come out with this technique, which is very, very commonly used in the midface fractures, that is submental anesthesia. Submental intubation is, we pass a tube through the submental, which comes in the floor of the mouth. The tube goes through the floor of the mouth, and that doesn't come in the way of the occlusion at all. So whatever occlusion we want, all the manipulations of the mandible and maxilla can be done without the hindrance of the tube, which is going to be used for intubation. So this is one of the routes where in the submental region we pass the tube. Initially it will be passed through the oral cavity, and then once we open through the submental, the tube will be taken through the submental route, and that will be connected to your dragger or whatever anesthetic station it is. So these are the anesthetic challenges which we face in maxillofacial midface fractures. If it is simple mandible, if the nasal bone is not fractured, we will directly go ahead with the nasal intubation. Now the surgical considerations would be anatomic reduction. I have told you this is required, but at the same time, the most important is the functional aspect that has to be dealt. I told you, having a very good union of mandible and maxilla, but at the same time, if the patient is unable to chew, if he is unable to open the mouth, then there is no moving in the management. Then we need to consider about the aesthetics aspect also. Why? An example I'll give in this is, when we manage the midface, the orbital zygomatico complex, zygomatico-maxillary complex, ZMCs, orbit and all, when we manage this case, if the post-operative, the patient has got dystopia in the sense, the level of the orbit, medial canthi and the lateral canthi, if they are not in level, then that doesn't give you a good appearance. All this can be managed during the surgery itself. We need to address all the aspects having the knowledge about the anatomy. The most important outcome should be minimum post-traumatic and post-surgery deformity. Timing of surgery for the midface is a very important aspect, but it is more of a debatable. Some people say that we will wait till the edema subsides. Some of the are of the opinion they will perform immediately. But anything done will have to be managed. The midface has to be managed within 2 weeks. After that, we cannot address as easily as possible if it is after 2 weeks. We need to have a customized approach for the patient, because I told you the LeFort 1 line, LeFort 2 line, LeFort 3 line and all will not be exacting the patients. So we need to customize our approach, and then contemporary analysis and staging of the injury has to be done, where we need ophthalmic intervention, we might need the ENT intervention, we might need the plastic surgery intervention. All these are required. Intubation, I've told you, is very, very significant, and then if possible, nasal is always advised. If nasal is not possible, then instead of going for tracheostomy, we can directly go with the submental anesthesia, intubation. Appropriate exposure of the buttress. I told you the significance of knowing the anatomy. We need to have a good anatomical knowledge about the buttress system of the face so that we can get the good reduction. Now, I think there are some of the cases which I have done. We can consider for the bone graft if it is very much comminuted and bone buttress has been lost. If bone gap is more than 5 centimeters, we can anytime think about the bone grafting, which we can take even the iliac crest, or you can take the fibula also. Now, this is one of the very, very important case. If you can see the fracture lines, this is an assault case. Now, no LeFort 1, 2, 3, or nothing can be matched. You can see the clinical photograph. This is how the patient presented to the hospital. Total midface is been avulsed. It has come to the right side. You can see one of the eye, only one eye is visible on the right side. The left eye has gone with the traumatic avulsion of the midface. Now, we managed, I told you see the buttress there. That is one side, the maxilla totally had receded down. If you can recollect this, I'll show you how the maxilla has receded down. It was totally floating. We could reduce that first in the buttress region, and then one side on the left side we have used the zygomatic buttress. On the right side, if you see the significance of the knowledge of the anatomy. If you can see the plating system which I have used, we can see the nasomaxillary buttress is addressed, the zygomatico-maxillary buttress is addressed, and even the pterygomaxillary buttress is addressed. Keeping the occlusion intact, this plating has been done. This is how the patient was post-operative. Now the patient appears like this post-operative, and he has got vision in both the eyes. Left eye appears to be slightly blurred, otherwise everything is fine with this vision. This is another case where this is a simple one, high LeFort 1 we can call. Okay, that can be managed by anyone. See, this is how the intubation, sometimes we can, if it is only zygomatic complex fracture where the dentoalveolar is not involved, we can directly go ahead with the oral intubation, whichever is possible. This is another case which I have done. This is the mandibular plating along with the maxilla. You can see here, again there is no explanation for LeFort 1, 2. We can have combinations of as many fractures as possible. The need to address the midface based on the buttresses. I've told you the nasomaxillary buttress, zygomatic, because we cannot plate it on the anterior wall of the maxilla, which is a very thin bone. So you can see all these cases can be managed keeping the buttresses in mind. These are all some of the cases. This is one case which I showed you. The midface, one side has gone totally up. You can see the plating which has been done. Light so that it can be visible. Light off. See this, if you can see the occlusion, how it was not suiting. One side was totally superior. You can see on the total to the right side, the occlusion, the maxillary teeth have gone up. And I could get that by reduction coming to the occlusion. At the same time, I'll do the plating. So that further, once we remove the intermaxillary fixation, the patient will be able to chew properly. This is his post-op. This is another case where there is a severe avulsion of the soft tissue in the midface. We could approach, you can see the parotid gland, you can see the facial nerves, everything. But the patient had no neural deficiencies later on. This was not how he was managed. You can see the plating system. Why I am highlighting this is, everyone should keep in mind about the buttress system. You can see the zygomatic buttress addressed. Instead of going in for a small piece which is there in the anterior wall of maxilla, addressing to that, we can go for the buttress so that you will get a good union and then better stability. Now, these are the developments which we can think about in the midface. That is, I have shown few of my cases which I have done in my practice. We can go for the computer-assisted surgery, endoscopy-assisted surgery, and then C-arms, which we know that orthopedics will regularly use. That can also be brought into the maxillofacial region with lot of inventions. To conclude, I would like to highlight the importance of the anatomical knowledge about the midface and then the buttress system, and to customize the treatment planning. Don't go ahead with the regular whatever incisions have been explained in the book. We have to follow them. At the same time, we need to customize for the patient specific needs. The priority of the management has to be seen. Now, whether to go ahead with reduction first or the emergency management first. And the secondary corrections of the deformities will have to be addressed at a later stage. The modern surgical management is continuing to get evolved, and let us involve in evolving the management reforms. Then imaging software improved, precise understanding and the treatment. Let us go into like 3D imaging techniques. Most of us are not much aware of that, how important it is. Once we get to know, if we use the patient-specific plating system, I think we will be able to follow that. And I thank you for giving me an opportunity. I thank the chairpersons and the audience for giving a chance for me to speak on this. Thank you for your patient listening.
Thank you, Dr. Joshi. Congratulations for your wonderful presentation. One clarification I would like to have, patients who are undergoing a submental intubation for facial injury, post-operative, how airway is maintained, either by tracheostomy?
Post-operative, usually sometimes when we get to know that post-operative the patient needs airway management, then we will think about, we can keep the submental tube itself there only. We don't
How long it is kept? How long it can be kept?
It can be kept the same as that of the oral, because we don't have any oral cavity. Why we need to remove intubation from the oral cavities? Lot of sloughing will be there. So we will remove the oral. But submental is as good as tracheostomy. We can keep it for 5 days, 10 days. But usually, most of the patients we will extubate immediately. But we have kept the patient for 5 days also on submental intubation.
Okay, thank you. House is open for questioning. Dr. Joshi is ready to answer.
Any questions from the audiences are welcome to the speaker. 5, 4, 3, 2, 1. No questions, we move on. Thank you so much, sir. Now I would like to request the chairpersons to felicitate Dr. Joshi, sir. Thank you, sir. I request the volunteer to please escort the speaker off the stage. Now request Dr. Zaman Musfi Madam, HOD of Forensic Medicine, Faculty of Medical Sciences, Kevin University, to please felicitate our chairpersons, Dr. Devni sir and Dr. Mushtaq sir. A big round of applause, audience. Thank you, ma'am. Thank you, sir. Now, we have the inaugural session to begin. We'll take 2 minutes to get the stage ready, so keep patient. Thank you. Everyone, I would request everyone in the audience to please settle so we can begin our inaugural session. I request the students to please settle down in the seat so we can begin with the inaugural session. I request the audience to settle down so we can begin the inaugural session. Good morning, everyone. Now, to begin the inaugural session, I would like to request the audience to involve the Almighty. With this, I request Janab Hafiz Muhammad Hashim Sahab to come up on the stage to recite the Khirat.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي खलक पढ़े अपने परवरदिगार आलम के नाम से जिसने पैदा फरमाया है। खलक़ल इंसाना मिन अलक़, जिसने इंसान को खून के खतरे से पैदा फरमाया। अपने रब्बे करीम के नाम से पढ़िए जिसने इंसान को कलम के ज़रिए से सिखाया। अल्लमल इंसान मा लम यअलम, इंसान को सिखाया जो कुछ उसने नहीं जानता था। आमन्तु बिल्लाहि व सदक़ल्लाहुल अज़ीम।
Shukriya Hafiz Saab. Now I'd like to request the volunteers to please escort the esteemed dignitaries onto the stage. Dr. Ali Raza Mosvi Sir, Honorable Vice Chancellor, KBN University. Dr. Rukhsar Fatima Madam, Registrar and Deputy Controller of Examinations, KBN University. Dr. Siddesh Sirwar Sir, Dean, Faculty of Medical Sciences, KBN University. Dr. Siddhaling Shankti Sir, Medical Superintendent, KBN Teaching and General Hospital. Thank you, sir. With this, I request Dr. Muhammad Ali Patel, sir, Head of the Department of Dentistry, Faculty of Medical Sciences, KBN University, and also the Organizing Secretary for today's conference, to deliver the welcome speech.
Good morning, everyone. Distinguished guests, esteemed speakers, participants, ladies and gentlemen. On behalf of the organizing committee, it is my privilege to welcome you all to this CPD program on oral maxillofacial surgery, the present and the future. To begin with, His Holiness, Janab Dr. Sayyid Shah Khusro Hussaini Sahib, Sajjad Nasheen Dargah Hazrat Khaja Bandanawaz, His Excellency the Chancellor, Khaja Bandanawaz University, Janab Sayyid Muhammad Ali Al Hussaini Sahib, the Honorable Pro-Chancellor, Khaja Bandanawaz University, Dr. Sayyid Mustafa Al Hussaini Sahib, the Director, Khaja Bandanawaz University, Dr. Ali Raza Mosvi Sir, Honorable Vice Chancellor, Khaja Bandanawaz University, Dr. Rukhsar Fatima Ma'am, Registrar, Khaja Bandanawaz University, Dr. Siddesh Sirwar Sir, the Dean, Faculty of Medical Sciences, KBN University, Dr. Siddhaling Shankti Sir, the Medical Superintendent, Faculty of Medical Sciences, KBN Teaching and General Hospital. I would like to welcome the principals of Al Baba Dental College, HKE Dental College, and ESIC Dental College. The HODs, professors, postgraduates, interns, and our sincere gratitude goes to our esteemed speakers who are here to generously share their knowledge, expertise, and insights throughout the conference. A warm and heartfelt welcome to all of you to this remarkable gathering, the Conference on Maxillofacial Surgery, the Present and the Future. It is with great pleasure and immense enthusiasm that we come together today to delve into the dynamic world of maxillofacial surgery. This conference is a celebration of innovation, expertise, and relentless pursuit of excellence in the field of maxillofacial surgery. As we gather here, we stand at the crossroads of the past and the future, reflecting on the remarkable progress made in this specialized branch of medicine and envisioning the endless possibilities that lie ahead. Together, we will explore cutting-edge technologies, research findings, and the integration of interdisciplinary approaches that have revolutionized patient care. This conference serves as a unique platform for the exchange of knowledge, ideas, and experiences, fostering collaborations and nurturing relationships among professionals in the field. We must recognize that the future of maxillofacial surgery holds immense promise. As we embark on this transformative journey, let us remember that our collective goal remains rooted in the well-being of our patients. The advancements we discuss and the insights we share should always be guided by compassion, ethics, and the commitment to delivering the highest standards of care. This conference is not only an opportunity to share knowledge and experiences, but also a chance to foster collaborations and innovations. Together we can envision the future of maxillofacial surgery and collectively contribute to the betterment of patient care. I encourage each and every one you to actively engage in discussions and network with your peers. Let us seize the moment to learn, inspire, and create a bright future. I extend my gratitude to all the speakers, the organizers, sponsors, and attendees whose dedication has made this conference possible. Your presence here today is a testament to your unwavering dedication to the advancement of maxillofacial surgery. May this conference be a source of inspiration, fostering collaborations that will shape the future of maxillofacial surgery and in turn improve the lives of countless patients worldwide. Once again, I welcome each and every one of you to this extraordinary event. Let us embark on this journey of discovery, unity, and progress together. Thank you, one and all.
Thank you, sir. Now I would like to request Dr. Siddesh Sarwar, sir, Dean, Faculty of Medical Sciences, to address the esteemed audience.
A very good morning to everyone. It gives me an immense pleasure to utmost respect to welcome our Chief Patrons, His Holiness Dr. Syed Khusro Hussaini Sahib Sajjad Nashin Dargah, Hazrat Khaja Bandanawaz, Honorable Chancellor Khaja Bandanawaz University and President Khaja Education Society. Sir has sent his best wishes and blessings to this continued professional development, this CME program. Was not able to make this program, and I also thank and with deep sense of gratitude I welcome our Dr. Syed Muhammad Ali Hussaini sir, the Honorable Pro Chancellor and Vice President Khaja Education Society, for his constant support and guidance for all our endeavors. Sir also was not able to make it, and it's my proud privilege to welcome our beloved Director, KBN University, Dr. Syed Mustafa Ali Hussaini sir. And with wholeheartedly, I welcome our patron, Honorable Vice Chancellor, Professor Ali Raza Muswi sir, who is a constant source of motivation and inspiration for all the scholastic programs of our KBN University. Under his guidance, many programs are happening back to back, and we are fortunate to have such an academician to our university, and we are truly delighted for this. I'm truly contented to welcome our patron, Professor Rukhsar Fatima Madam, the in-charge registrar, Khaja Bandanawaz University, and we are very much thankful for her support for all our programs. And it also gives me great pleasure to welcome all the organizing committee members, especially the organizing secretary, the Department of Dentistry, headed by Dr. Ali Patel, who has done a tremendous and wonderful job, commendable job for organizing this program. I think this is the first time medical college with the specialty dental department hosting this continued program, which is a commendable job. And we are truly elated for the team, Dr. Muswi, Zama Muswi, who is also organizing secretary, and the other complete team who are involved in this, that is Dr. Vikar Ahmed, Dr. Jui, and other staff members, and all the HODs of the different departments of the college side, hospital side, who are the organizing members for this program. And we are also glad and welcome the advisory committee members, our senior CEO, P.S. Shankar sir, our beloved medical superintendent, Dr. Sidling Chinti, and head of the department and IQAC director, Dr. Basir, and Dr. Bilal, head of the department, and all the principals of the dental college, especially my friend, Dr. Zakaullah, the principal, Al-Badr Dental College, and other dental college principals, Dr. Arvind Maldi, Dr. Prashant, and Dr. Arshad Hussain, Vice Principal, Al-Badr Dental College. Indeed, we are also glad to have the specialist or the expertise speakers whom we have today for this CMA program, Dr. Nagarajappa Das, Honorable Secretary, Karnataka State Association of Oromaxillofacial Surgeon, and also Dr. Srinath, Honorable President for the Association Oral Maxillofacial Surgeons. For these two members, for the association members, we thank them for coming over here and sharing their expertise. And also thank our own resource persons of our place, Dr. Neelkant Hallur and Dr. Udupi Krishna. And with the national fame, we also welcome Dr. David Taro and Dr. Girish Kora and Dr. Ramana Reddy. All these faculties, I am quite sure that they make this CME a wonderful academic feast. I hope that this gathering of the CME will definitely galvanize, or rather we would say expertise you with the sharing of their experiences, and in this turn you can pass on your services, good services to the society and to your patient. With these few words, I once again thank and I wish a very grand success for this CMA program. Thank you.
Thank you, sir. Now, to honor our patrons, I'd like to request Dr. Sidney Server, sir, to present the bouquet to Dr. Ali Raza Moosvi, sir, Honorable Vice Chancellor, KBN University. Thank you, sir. I request Dr. Zaman Moosvi Madam to present the bouquet to Dr. Rukhsar Fatima Madam, Registrar and Deputy Controller of Examinations, KBN University. Thank you, madam. Now, I request Dr. Guru Prasad sir, Professor in HOD Department of Dermatology, to present the bouquet to Dr. Siddhesh Silver sir, Dean Faculty of Medical Sciences, KBN University. Thank you, sir. Now I request Dr. Sachin Shah, sir, HOD, Department of Orthopedics, Faculty of Medical Sciences, KBN University, to present the bouquet to Dr. Sidling Shanti, sir, Medical Superintendent, KBN Teaching and General Hospital. Thank you, sir. Moving on to the inaugural session, I request Dr. Ali Raza Muswi, sir, the Honorable Vice Chancellor of KBN University, to felicitate Dr. Syed Zakarullah, sir, Dean Al-Badr Dental College. Thank you, sir. I request Dr. Ali Raza Muswi, sir, to felicitate Dr. Arvind Moldi, sir, in charge principal, Dean, HK Dental College. Dr. Arvind Moldi, sir. I request Dr. Satish Patil, sir, to please come up on the stage. Thank you, sir. I request Dr. Ali Raza Muswi, sir, to felicitate Dr. Prashant Patil, sir, Dean ESI Dental College. A big round of applause. Thank you, sir. I request Dr. Ali Raza Muswi, sir, Honorable Vice Chancellor, KBN University, to address the esteemed audience.
Very good morning to all of you. I begin by, of course, thanking the Honorable Chancellor and the Pro-Chancellor who could not be with us today for this function. But I'm glad that we are having this function today. As you all know, we complete 5 years as a university this year. And the medical college, the engineering college, the BA, law, all these were separate elements which has now been amalgamated as a university. Any university has to build a research profile. It cannot just be engaged with teaching. Keeping this in mind, we at this university over the last few months have started a robust program of academic events, academic interactions, where we invite and involve outside experts to be part of our research and academic growth, to contribute, to participate. I believe that the main way any university or college grows is through exposure, interaction. Because this CME program or a workshop or a conference, these are, as I've also remarked earlier, windows to the outside world. Once we look outside, then we get into a comparative mode, a competitive mode, and then we try to emulate, we try to adopt, we try to adapt to best practices which exist elsewhere. I would like to thank all the experts, leading lights in the field who have taken the time out to travel to this town and to be with us today. I also thank Dr. Ali for taking this opportunity, for putting this all together. I have often observed that the dental department is very low in the pecking order as far as a medical college is concerned. But I think that as far as oral and maxillofacial surgery is concerned, because my exposure, I am from the field of earth science. I am a total outsider and a stranger to medical science. I have had no formal exposure. I have had no formal training, and on the contrary, hospitals were places which were to be avoided. So it's not that we have a very healthy relationship with the medical sciences as users of the medical science, but as a Vice Chancellor, I have come to believe, I have come to understand the complex role that medical science plays in our lives. When I saw this today's the theme, maxillofacial and oral, maxillofacial field, because I recall that it's been about 2 decades or less that when I used to visit Dharwad, the SDM college from where my wife is a student, I recall then they had a very advanced trauma center at that time, I don't know, 2005, 6, 7, and it always intrigued me as to what it is that these dental surgeons do. Now there are 2 themes which, as an outsider, I can speak about as far as the entire field of the field of dentistry is concerned. The first part is, of course, alleviating pain, addressing to problems of teeth and all that. The second part, which has now become more important, is oral and maxillofacial, aesthetics, teeth whitening, beauty, because the jaws, our teeth, take up half of our face, and we place, and in today's world, we place a lot of importance on how we look. So that has become a very important and growing area as far as aesthetics is concerned, as far as dental correction is concerned. Now, the present of oral maxillofacial, I think, would be whatever new technologies are in place. But as far as the future is concerned, I think that this field will slowly be integrated more and more into emergency, casualty practices. And Dr. Ali also heads our newly opened casualty wing because of his expertise in oral and maxillofacial surgeries. As a university, I would also like to comment and then, of course, conclude that we are a very diverse institution with about 8 faculties, 32 departments offering 51 programs. My idea and my input to all of you here, as far as our own faculty is concerned, is that the focus should be excellence. We all have to work together to achieve excellence, which comes through standard operating protocols, procedures, and a very robust feedback mechanism which informs us what we are doing, what we are not doing, what we ought to be doing, and what we should be avoiding. And all these things come from, as far as an administrator is concerned, it comes from 3 broad fields. The first is coming together on one idea and one thought. The second is having a very healthy feeling of teamwork. And the third is always keeping a focus on your professional commitment to the institution. In administration, we often, since I have spent nearly 20 years in various government institutions, we always say there are 2 approaches to administration, the ABC of administration. The first is ABC is avoid, block, or confuse. That's one way to administer. The second is, the A should stand for always be attentive. B should be that you should always care. I mean, you should always, A should be always listen, B should be attentive, and C should be care for the institution. Now, I would like our employees also to have this ABC approach to their own work. I would also like our students also to have this ABC approach towards their work, where we can and we will, God willing, in a year from now, build a robust and strong academic structure which suits a university. And that has been my intention throughout, because the hospital is 22 years old, I think, Dr. Siddesh? 22 years old. And it has grown and flourished as a very good institution. Now, we would like to also make it to contribute to research and to have a focus towards research. I'm very happy that over the last year, I think 6 or 8 departments from various parts of the universities have held such academic programs. I encourage every department, every dean, every head to submit proposals which we will wholeheartedly support. And I also expect, like it was done the last time, that there will be a proper documentation of what is happening here today, so that we can look back to it and also take it the next step. Because this is part of a process, it's not an event that it is held once. It is a process, a very long process, maybe tedious, but a process that will ensure that we attain academic excellence. With these words, I thank all of you for being here. I thank the organizers for having us here. And I wish this the very best. Thank you.
Thank you, sir. Now I would like to call upon Dr. Juhi Shabnam, Assistant Professor, Department of Dentistry, Faculty of Medical Sciences, KBN University, to deliver the vote of thanks.
Good morning to everyone. I'm extremely thankful on behalf of the organizing committee of this program to the Honorable Vice Chancellor, sir, for giving us the opportunity to conduct this inaugural function. I'm extremely grateful to the Vice Chancellor, sir. Excuse me. I'm grateful to the organizing committee of this program, to the Honorable Chancellor, sir, Pro-Chancellor, sir, Medical Director, to our Dean and Principal and our Medical Superintendent for giving us an opportunity to conduct this inaugural function. I am extremely thankful to the Honorable Vice Chancellor, Dr. Alireza Losvi, sir, for coming all the way in his busy schedule for the inauguration of this function. Thank you, sir. I am extremely thankful to the Registrar and Controller, Dr. Riksar Fatima ma'am, for coming all the way in her schedule for this inauguration of this function. I am also thankful to the Dean and Principal, Dr. Siddeshwar, sir, for presiding over the function. I am grateful to Dr. Siddesh Chaitya, sir, for presiding over this function. I also extend my sincere thanks to all the eminent speaker, delegates, and students for attending this inauguration function. I am thankful to the non-teaching staff and helpers for helping endlessly. They say that the greatest gift you can give someone is your time, because when you give your time, you're giving a portion of your life that will never get back. Thank you everyone for giving us your valuable time today. I apologize if I have forgot someone. I thank everyone from the bottom of my heart. Thank you, sir.
Thank you, ma'am. Now I'd like to request the volunteers to please escort the dignitaries to the tea area. And to the audience, please enjoy the tea which is arranged, and we'll assemble again in the auditorium at 12 o'clock sharp to start with the next lecture. Thank you. Hope you all enjoyed the tea. Moving on to a scientific session, I would like to invite on stage the chairpersons, Dr. Sayyida Arshia Madam, Professor and Head of the Department of Oral Medicine and Radiology, Al-Badr Dental College. Dr. Sayyida Arshia Madam. Dr. Pranesh Kulkarni, sir, Professor and Head of the Department of Ophthalmology, Faculty of Medical Sciences, KBN University. Dr. Pranesh Kulkarni, sir. Dr. Shireen Fatima, Madam, Professor of Oral Maxillofacial Surgery, Al-Badr Dental College. Manish Kulkarni, sir. And to introduce the next speaker, I'd like to request Dr. Juhi Shabnam, Madam, Assistant Professor, Department of Dentistry, Faculty of Medical Sciences, to please come up on the stage and introduce.
Good day, everyone. It is my pleasure to introduce our next renowned speaker of the day, Dr. Neel Kamal Hallu, sir, my teacher, my mentor, my guide. He is the professor, HOD, and PhD guide at Department of Oral Maxillofacial Surgery, Al-Badr Rural Dental College and Hospital. His education is from KLE Society Dental College and Hospital, Belgaum, where he finished his BDS and MDS. He is a diplomat and fellowship at the International Congress of Oral Implantologists, USA. To his training accreditations, Sir has trained for a period of 1 year at the Malia Hospital under Dr. Kishore Naik and Dr. Sanjeev Naya, sir, at the Kidwell Memorial Institute of Oncology, Bangalore, for a period of 1.5 years under Dr. S.V. Kumaraswamy and Dr. Vijay Kumar. Sir has been trained by the very famous Dr. Adewale, sir, at the Charles Porter Center for Cleft Lip and Palate, Trishur, Kerala. Sir has finished his temporal joint surgery course at VNSORG course at Kuala Lumpur, Malaysia in September 2019. He has done the third TMG course at Amrita Institute of Medical Sciences, Kochi in September 2019. With his area of interest in oral and maxillofacial trauma, orthodontic surgery, oral oncology, and dental implants, and with wide teaching experience of 26 years, he has more than 35 international publications to his credit. He has been a guide to over 25 students, has been a faculty and a keynote speaker on several occasions. Sir has given guest lectures in international and national conferences many times. He has over 22 paper presentations to his credit and attended various conferences and workshops. I now welcome Dr. Neel Kamal Hallu, sir, to the stage.
Thank you very much. Good afternoon to all. Respected Vice Chancellor, Registrar, KBN University, respected senior principals, faculties, and everyone, respected chairpersons. First thing I like to thank organizing committee of KBN Medical College Dental Unit for giving me an opportunity to discuss on oral and maxillofacial surgery. Really thanks to all. First thing I like to welcome our Karnataka State Chapter President, Dr. N. Srinath, very close friend of mine. Welcome, Dr. Srinath. Second thing I like to welcome our Secretary, Karnataka State Chapter. Already has given a lecture. Thank you very much from Chitradurga. Third thing I like to welcome our past President, Dr. David Terraro is my very close friend. All the way has come, one of the great speaker, surgeon of the scene. Thank you. Welcome, Dr. David. And other speakers. Actually, Dr. Ali has talked me, sir, we want to have you as a speaker and we want to discuss something about maxillofacial surgery. And already our seniors were discussing about trauma and what is upcoming in maxillofacial surgery. I told you one is temporomandibular joint. This is one which ourselves has to venture and do a lot of research, and it is one thing which is most of the medical faculties also should know what is temporomandibular joint, what is the function of temporomandibular joint, what is the pathology, disease, and what are the upcoming on temporomandibular joint here. Thank you. Let me start. This is a video. I think why it is very its joint is one that video itself tells what's the importance of temporomandibular joint. The whole video. I think it's a very funny video, but we can use in chewing, sucking, swallowing, speech, facial expressions, breathing, protrusion, retrusion, and lateral movement of the jaw, and opening of the mouth, also very important, maintaining of the TMJ. So the joint is one of the most important of all the joints in our body because the whole day-to-day life is maintained on this joint here. It is one of the most complex joint movement of all the joint movement because if you see it has got all the three-dimensional movements. It's the only joint in the body. It's only joint in the body which has got a three-dimensional movement where we have to do a lateral movement, anterior movement, posterior movement, chewing movement, and all the three-dimensional movements is available. And another most important of all the joint in our body, all the joint of body are separate. Your leg joint is separate, knee joint is separate, femur joint is separate, but this is the only joint in the body where simultaneously interrelated. Once you open the right joint, you're going to open the left side. If you're going to open the left side, any problem, then we are going to affect on the joint. This is the only joint in the body where right and left joint are going to move simultaneously, and whatever the functions and whatever that happens to the other joint, it is also going to affect the right and left other joints here. So it's one of the very complex joint of all the joints in the body. So this is a video, what exactly, how does the joint, it is moves here, and any changes in this joint, because see how joint beautifully moves here. This is an articular disc, this upper and lower joint, and any changes which is taken this in the complex structure leads to the change is called as it is called articular disc and biomechanics of the joint. Any changes which is causing called as a pain, one sound is called a click, other is going to call the lock. This is called internal derangement. Any changes which is caused abnormal in the normal movement of the joint is called internal derangement. So today's my topic is on upcoming topic that is called arthroscope. And what is arthroscope is a special scope which is devised for like any other medical practitioner. You will be using like an orthopedic surgeon, you will be for a knee joint or a other joint where the processing the same has also has come to the temporomandibular joint is called arthroscope. We are going to put a scope, we are going to see in the monitor, and we are going to do evaluate it. And the next is if the joint is totally damaged, which cannot be repaired by any of this conservative treatment, and I'm going to discuss that is called as total joint replacement. I think you must be hearing about hip replacement or a knee replacement or a joint replacement. The same type of the replacement we are also going to do in the joint is called as total joint reconstruction. That's what I'm going to discuss today. I'm Dr. Nilkamal. I think already one of my students already introduced to me. And what are the main patients? Patient always comes to you with one of the very classical sign is pain on the both joint. It may be right side or it may be left joint, and swelling on the joint, and morning stiffness. Morning stiffness is one of the very classical sign of this temporomandibular joint. And whenever you open and close mouth, I told you all the pathology, the sounds like click or popping sound or locking of the jaw, they are the classically which is related to the temporomandibular joint. And that is a video where we can see how the clock, wherever this articular disc stuck, the patient will be getting that called as a sound which is called as a click which comes there. That is show that there is some internal derangement of the normal movement of the joint here. Other signs, patient will open, there is a change in occlusion. Once a change in occlusion, patient will have difficulty in day-to-day routine food. Patient is not able to eat food on the both the side. They have a discomfort and loss of the function. And sometimes these pain also radiate to the head, that is called patient complaint of headache, dizziness, and ear pain. So most of the ENTs, they get confused. They need one more opinion from maxillofacial surgeon that they have to rule out temporomandibular joint. The neurosurgeon has to rule out temporomandibular joint. ophthalmologist has to rule out temporomandibular joint. So this joint pain has to be ruled out from medical faculty before concluding their treatment plan. Then what are the most of the causes of the trauma? Microtrauma. They must have been childhood injury, they must have been fell down, maybe a road traffic accident, they may have been assault. Most of these joint injuries are history of the trauma during their childhood or early childhood or any time which may cause the trauma there. And sometime during surgical procedures, as you know, sometimes endoscopic procedures or during anesthesia procedures or bronchoscopic procedures or ENT procedure also must have been caused excess mouth opening during their sedation, where the joint must have been caused the internal derangement. And other microtraumas, also sometimes dental procedures. Most of our dental faculties or dental procedures are doing a long-term dental procedures without taking care of the putting a mouth probe. And sometimes the dental treatments where the high points are more, or if your complete denture jaw relation is more, or it may be related to your implants where the total rehabilitation of the implant is done where adequate jaw relation and vertical height is not maintained, they may lead to this thing. And other causes also like parafunctional. You must have been seen nowadays most of them have a habit of chewing the chewing gums. Continuously they'll be chewing some 3 to 4 or 5 to 6 chewing gums. They also end up into some amount of early internal derangement. Clenching of the teeth, bruxism, they also causes internal derangement. What are systemic conditions? Sometimes these generalized systemic conditions like rheumatoid arthritis or osteoarthritis or psoriasis, they also end up into joint problems, and the synovial fluid is inflamed in this joint is called as sinusitis. So all rheumatologists or general medicine faculty also should evaluate temporomandibular joint conditions, that these conditions also affect the TMJ with the pain and they may need a treatment for this. So clinical examination, as usual, we do clinical examination of the joint, open mouth, closed mouth, lateral mouth, whether the joint is restricted, and we also auscultate this joint to see any sounds are there, the popping sound, the click sounds, so they have to be evaluated. And one of the most common X-rays we call as OPG, it's called as orthopantomogram, where completely the right and left joint will be seen in one X-ray, and completely you can evaluate what is the pathology of the joint and what is the dental condition. And another condition is called as open and closed mouth X-ray. These are the very two important basic X-rays you'll be reading for the temporomandibular joint diagnosis, for early diagnosis. But the problem is, they give only two-dimensional. They don't have three-dimensional view. Then we'll go for, that is called as CBCT. What is CBCT? CBCT is cone beam computer tomography. Whatever the CT scan is available, the higher version of the CT scan exclusively designed for maxillofacial surgery and maxillofacial evaluation of the pathology is called as cone beam computer tomography. In cone beam computer tomography, we evaluate all the three-dimensional changes which has been taken place in the joint, whether the joint is eroded, whether the joint is artifact, whether the joint has early fractures, all it can be evaluated here. But again, what is the drawback here? It doesn't give any soft tissue information about the joint here. The soft tissue information joint will be going for MRI. MRI is exclusively give what are the soft tissue changes which is taken the place called articular disc, whether it is a ruptured, whether it is a perforation, whether it is any effusion of the synovial fluid, all will be evaluated in MRI. And nowadays we can recall as dynamic MRI. This is a dynamic MRI. Exactly, dynamic MRI gives you complete information about the joint and the internal joint movement, what exactly the pathology is taking place. So all these are the basic investigation we to rule out for the temporomandibular joint. And other important, whenever doing a temporomandibular joint, we have to evaluate is there any neurological problem, is there any ear problems, or dental problems, or neck problems, and ophthalmology problem, you may need to take a cross-reference of these patients to evaluate pathology. Sometimes, recently, most of us use, I think, they put a lot of this thing to listen continuous music and keep on talking there. And some about the pressure effect may lead to the internal derangement. These are the most of the commonly we seeing. Few of my patients are very common. At least once in a month, I see 2-3 patients. These marketing people, they keep earphone and keep on talking hours together. So they all causes internal derangement. Then non-surgical management is very simple. Usually, what happens? We educate the patient first. These patient education, and take a soft diet. Avoid excessive movement of the joint, like lateral movement or excessive mouth opening should be avoided. And if patient is having clinching, we tell them about the clinching habit, orthodontic treatment, massage, and some of the patient also will be having they called as stress strain. Sometimes these patients also may need a psychological counseling to avoid if any habits are there. And other treatment like painkillers, what we call NSAIDs, muscle relaxants, tricyclic antidepressant with the prescription, with the opinion from psychiatrist, not directly, we don't deal with this. Any sedatives, if patient is stress strain, and Botox, that's the recent treatment. Non-invasive treatment, this is also called as complementary treatment, that is called as trans-electrical nerve stimulation. This is also going to help a lot. Next is, we can give an ultrasounds to the temperament. There is a special cone is available from the ultrasound, where the ultrasound, the cone will be applied on the temporomandibular joint, early stages of internal derangement. That's also gone results. And thermal, there are special thermal packs are available for they can educate the patient to apply the thermal pack. The most latest is low lever laser therapy. Lot of evidence-based documentation and research has been concluded that low lever laser therapy is going to help for early internal derangement as a complementary treatment. They are not, these treatments they never cure internal derangement. They help to reduce the pain and part. And this is one of the most important, the splint. We can take an upper and lower models and we can give a soft splint of 3 millimeters and 5 millimeters. What is the function of a splint? It reduces the pressure. It reduces the pressure over the joint here around 5 millimeters, and most of the pain will be reduced here. So this is most acceptable treatment. They are all conservative line of treatment. After doing all this treatment, patient has got still pain. What's the treatment now? All conservative drug treatment, laser treatment, everything work, then we going for arthroscope. So arthroscope is indicated for the internal derangement of the joint where all conservative line of the treatment have been failed. Then we go for arthroscope. As I told you, arthroscope is a very special designed, we have a 1.4 to 1.8 mm diameter. We exactly go to the joint and we visualize the joint and we have to evaluate what are the pathology there. What are you going to see in the, this is one video, I think slightly a very big video. It is a video from our Nehal Patel, actually taken from Nehal Patel. He is one of maximum doing orthoscopic joint surgeries in our part. And first, I think this slightly bigger video, I think I'll just give you how orthoscope procedures will be done. The diagnostic orthoscopic procedure we can do under local anesthesia. The therapeutic orthoscopic, definitely we need a general anesthesia. We cannot do under local anesthesia, this procedure. Next fast. Scroll fast, Sadhana. These are the instrument and we are going to see the orthoscope. Yeah, that's a backflow which is coming from the joint. Fast. Yeah. This is how the scope will be. These are the different anatomies of the joint, what all has to be evaluated. Fast. Okay. This is how we are going to see the joint. What all the pathology is there, what all the changes is there. What all you can see in our orthoscope, we can see is there any adhesions of the temporomandibular joint to the articular disc, why it is pain is there. Is there any articular disc is come to superior position, or are there any changes on head of the condyle, and is there articular disc is totally displaced, or articular disc is elongated or inflamed, or articular disc is ruptured, or is there any complete articular depth, articular discal perforation is there. This all has to be, we can evaluate it in this orthoscope. And also we can see whether your head of the condyle is normal, whether it is flattened, whether it is sclerosed, whether it is osteophytes or erosions. This all can be evaluated in the orthoscope. Then what we are going to do, first procedure is called as orthosynthesis. Earlier we used to do blind orthosynthesis to cleaning up the joint. Now we are doing orthoscopic guided orthosynthesis. So what we do, we put an orthoscope and we take around 20 to 30 ml of the saline. We clean the joint so that all the synovial or inflamed synovial fluid will be cleaned, and we inject some steroid, that is dexamethasone, or we can use betamethasone as an anti-inflammatory, and 90% of the early joint pain have been vanished, and 90% have vanished. They do very well. And which is eliminates, and what is the indication? It eliminates all the inflammatory synovial contents and clear the joint, and joint makes to open wide. And what all other position we can do? Play the video. Whenever there is, we can see the video, earlier video also, when the disc comes to the anterior portion, that is called closed lock. Patient cannot open that. What we used to do earlier, we used to do open procedure, get the disc reposition back and suture it here. But same procedure, what we can do here, see this is called a closed lock. So sometimes what happens, disc comes here and stuck there, the patient cannot open it. So same procedure we can do with orthoscope without doing an open surgery, that is called discophyxy. So this also procedure we can do with orthoscope here. This is one of the patient, she is a school teacher. Actually, we see her mandibular movement. She had a very difficult mandibular movement. She is not able to do, see the close. She has a chronic pain, restricted motion, click, and a lot of degenerative. See, right and left side it is coming back. And we did an orthoscopic guided orthosynthesis, and that is a post-operative video. Play that video, Sadanand. See the post-operative video of that joint. She is quite out of pain. Her mouth opening is normal. Her taking class with the school teacher is absolutely comfortable. She don't have any changes in the movement. So these are what we can achieve from orthoscope. Next, this is next please. This is stage 5. There's a late degenerative stage. Actually, when she was a 10th standard, she fell down from her bike. She had a very painful this thing. I think the left side, the joint was totally eroded and smaller in size. She had a severe click. And in MRI shows there's a rupture of an articular disc here, and it is also very small. And see what exactly it is eroded, and very advanced degenerative because of more than it is a chronic. And post-operative video, can you show the post-operative video? So this is the post-operative video. See, her mouth opening is come to normal. She's out of the pain. All her lateral movements are fine. So this is an orthoscope here. So next important is temporomandibular joint ankylosis. So what happened when the child fell down during a childhood, or there is an intra-articular hematoma or heme arthrosis, end up into the head of the condyle is fused with your gynoid fossa and zygomatic arch, and patient is not able to open wide. They end up into severe facial deformities, and the whole condyle, what we do, the procedure is called as, very well known, this Alcaid-Bramley incision, and we remove this condylar part, and we ask the patient to do mouth opening, so patient will be normal. So this is two cases. One case is with a severe facial deformity of the post-ankylotic, and we are released. These are mouth opening. Most of this patient will have facial asymmetry, and we do orthognathic and orthomorphic. They are the combined surgeries will be done for these patients, and we rotate them back, and these patients almost they are near to normal. Can you see this patient pre and a post, and is a mouth opening there? And this is another patient. Sometimes if a bilateral ankylosis, they call it as a bird face deformity, where the patient that looks like a bird. The severe deformity will be there. Sometimes we cannot do an orthognathic procedure because bone will be very less for this patient, and we have to distract the bone. That is called as distraction osteogenesis. So we do, along with your 3D models, we plan the 3D models, type and types of the distractor, and we have to distract and get it to the normal. The next is total joint reconstruction. Where we reconstruct, the whole procedure, this is indicated into the where the joint has been completely once you removed after the temporomandibular joint, so something has to reconstruct here. That is called as total joint reconstruction. They are indicated into severe degenerative changes where all your conservative line of the treatment have been failed. They are indicated in other osteoarthritis patient where your joint is totally eroded, head of the condyle is totally gone, where they cannot do the reconstruction. And rheumatoid arthritis patient, osteoarthritis patient, where conservative line of treatment. And these are the neoplasm of temporomandibular joint, where we have like chondromas, osteomas, osteochondromas, where we patient need aggressive resection of this point, and we have to rehabilitate the function and aesthetic of the joint, so we go for total joint reconstruction. Other congenital disorders like hemifacial microsomias and Treacher colon syndromes, where the condyle is not at all developed here. So this is one of the case. Actually, she is reported to us with total condylar head to the ramus part is not at all regenerated here. And one of the major problem is she's not able to chew her day-to-day food from last 30 years, 32 years. That was a major problem here. The whole joint was damaged, and we planned for this patient. We taken a CT scan. After the CT scan, we get a 3D model called as ST models. These models will be transferred to called as virtual stimulate treatment plan, because reconstruction of the joint is very important, because I told you, right and left side we have to plan together. That is called as virtual treatment planning. After virtual treatment planning will be discussed, and we have made, these are the virtual treatment planning guide. After that, we are going to get the virtual treatment planning, we get transferred to surgical guide, exactly how many millimeters of the bone has to be removed. Then we get a trial guide. So exactly the trial guide is the one exactly we'll place into the OT, and this is a patient specific, because sometimes this patient will not be having the regular total joint reconstruction. They call it as a patient specific temporomandibular joint reconstruction. This is how much is the guide. Can you play the video? This is how we have planned for reconstruction with that trial guide. Once a trial guide and everything is fine, then we go for the final fixation of the TJR. Can you play the video? This is how you can see the joint, how exactly joint is moving almost to the normal here. We have fixed it. And this is pre and post. This is a pre-operative, we can see the defect, and post-operative. This is a pre-operative video and post-operative video. Can you play the post-operative video? See, she is quite comfortable. She is able to chew her day-to-day food, which was not able to chew for more than 30 years. That's total joint reconstruction can be done successfully. So this is another case. This patient, Nizam, reported to the department. We had patient had almost, it is a post-traumatic this thing. We thought it may be a benign tumor, but turned out to be a lot of malunited head of the condyle. And we resected that. It's the same procedure with an alkyl Bramley. The whole condylar head was removed. And this is called as stock implant, where we got it from the company, because we don't go for a patient-specific TJR. From the same TJR, we have been, that company we taken from Orthomax. It's an Indian company, because other imported TJRs are very expensive, but they are doing the function. Can you play the video? This is OPG after the post-operative fixation of the condyle and condyle head, and this is this thing. This is also, patient is very happy with regular diet. I really thanks giving me an opportunity and discussing about the recent advanced TIJ. This is my department, Dr. Aisha and Dr. Zaka and Dr. Chaitanya. Already Shirin is my chairperson here. Manazar, then Tasim was, and Kiran. We done almost 3 thesis topic in our department, 2 TGR reconstructions, and more than around 20-25 patients of ankylosis we operated. I think this future lot of scope for orthoscope and TGR. Thank you. Any questions? Because a lot of medical faculty, medical students, and these things, you have any questions on TMA or orthoscope or TGR, you can ask me.
Thank you, sir. It was a very informative session.
I like to forget, one is Dr. Sanjay Gandhi, Trauma Center Maxillofacial Surgeon, Dr. Gowda, he's also very close. I just forgot to mention earlier. Welcome, Doctor. Thank you.
Thank you so much, sir. Sir, I had one query.
Yeah.
TMJ arthroscopy.
No, you cannot ask query, you are with me only. Any of you ask.
Sir, arthroscopy,
Yeah.
because even I'm suffering with the same issue, you know about it. So, arthroscopy can serve better as a diagnostic procedure or minimal invasive procedure.
See, orthoscope is almost as you discussed. First we'll go for clinical examination, then we'll go for OPG, then we'll go for a CBCT, then even dynamic MRI. After dynamic MRI, we do all the conservative line of treatment. After all the conservative line of treatment, still you feel the same signs and symptoms, then we can go for diagnostic and therapeutic one stage only. There's no need to do a diagnostic thoracoscopy and wait and watch. You can plan for diagnostic as well as therapeutic.
Thank you so much, sir.
Good afternoon, everyone. At the outset, I would like to congratulate Dr. Ali, Dr. Vikhar, Dr. Joey, and all his team members for organizing such a wonderful continuing professional development program, especially in our medical institute. So once again, I congratulate you all, and especially with this renowned galaxy of speakers as oral and maxillofacial surgeons, which will take dentistry into the new heights. And there was one mention from the Vice Chancellor that the dental department is being least noted. I think with this program that is being organized by the dental faculty of a medical institute, it will make you all famous with this renowned galaxy of speakers. And I would also like to thank the organizing team for giving us the opportunity to be chairpersons for this wonderful and renowned personality, Dr. Nilkamal sir. I congratulate you, sir, for your wonderful and informative session of such a complex TMJ topic to making it so simplified and covering all the aspects right from your the conservative management and taking to the new advanced imaging modalities and also the reconstruction procedures with 3D printing and the orthoplastic surgeries and all. I once again congratulate you, sir, for your wonderful presentation. Thank you, Anand.
Thank you, sir. Thank you, ma'am. Now I'd like to request the chairpersons to felicitate Dr. Nilkamal, sir. Thank you, ma'am. Thank you, sir. Now I'd like to request Dr. Chandrakala, madam, Professor and Head of the Department of General Medicine, Faculty of Medical Sciences, KBNU, to felicitate our chairpersons. Thank you, ma'am. Now, moving on to our scientific session, I would like to invite on stage the chairpersons, Dr. Arshad Hussain, sir, Professor, Department of Orthodontics, and also the Vice Principal of Al-Badr Dental College, to please come up on the stage. Dr. Satish, sir, Professor, Department of Maxillofacial Surgery, HKE Dental College. And to introduce our next speaker for the scientific session, I request Dr. Muhammad Ali Patel, sir, Professor and Head of the Department of Dentistry, Faculty of Medical Sciences, KBN University, to please come up on the dais and introduce our speaker.
Thank you, Irfan. Good afternoon, everyone. It gives me immense pleasure to introduce one of the most distinguished speakers of the day, Dr. David Toro. Sir has done his BDS from Rajiv Gandhi University of Health Sciences in the year 1989 and his MDS from SGM College of Dental Sciences, Dharwad, in the year 1995. He is the Chief Consultant and Managing Director of the Tollins Clinic, Center for Craniomaxillofacial Plastic and Reconstructive Surgery, Bangalore. He has various achievements to his name. He was the past president of the Association of Oral and Maxillofacial Surgeons of India, the past president of the Indian Society of Facial Plastic and Reconstructive Surgery. He has an experience of more than 34 years in the field. Sir also had a stint at the Center for Burns, Plastic and Maxillofacial Surgery at the St. Lawrence Hospital in South Wales in the United Kingdom. He has worked with several cosmetic surgeons in Bangalore and abroad, and particularly trained with the internationally acclaimed surgeon, Professor Paul Salins, for a protracted period of nearly 8 years. Sir is an honorary professor and consultant CMF surgeon, Department of Craniomaxillofacial Surgery, Mazumdar Shaw Cancer Center and Narayana Hrudayalaya Super Specialty Hospitals, Bangalore. He has various fellowships to his name. He is a fellow and the on-board of examiners of the Royal College of Surgeons of Edinburgh, UK. He is also a fellow of the Royal College of Surgeons and Physicians at Glasgow, UK. He is also a fellow of the Indian Board of the Oral and Maxillofacial Surgery. Sir is a diplomat, National Board of Oral and Maxillofacial Surgery, India. He has received many awards, 2 national and 4 state awards. He received the Rashtriya Vikas Ratan Award, Individual Achievement for Economic and Social Development, IIGS, Delhi, in the year March 2006. He also received the State Award, Gold Medal and Silver Plaque in recognition of the exemplary services in maxillofacial surgery rendered to the rural population in and around the state of Karnataka, awarded on the 56th Independence Day celebration by the Minister of State for Sports, District Commissioner and Superintendent of Police of Davangere, Karnataka on 15th of August 2002. He is a member of various associations, and beside his passion for surgery, he has other diverse interests such as photography, Western classical music, travel, reading, culinary interest, and gardening. I welcome David Toro on the stage. Hello.
Hello, check. Very good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Thank you very much, Ali, for that introduction. I don't know where I got this information from, don't believe much of it. Anyway, thank you, Chairman. It's indeed a pleasure to be here in Gulbarga. This is my first ever visit in my life to Gulbarga. Thank you so much for this invitation. Thank you, Dr. Ali, the team, and the KBN University. When I was asked to speak on something, I said I would probably give you a topic to speak on, but then it was much to my chagrin and surprise that I saw this topic that was just printed without my knowledge. Believe me. This is what Ali said you're talking about, orthopedic surgery, craniofacial surgery. And I said, well, possibly yes, but nevertheless, I think orthodontic and craniofacial surgery, that's a pretty diverse topic. And if I could talk about orthopedic surgery, probably I could talk about orthopedic surgery for the entire day. But if I could talk about craniofacial surgery, probably maybe 2 days. So I said, there's something I need to do about this. This was the title that was given to me. Can I have a show of hands of the maxillofacial guys here, postgraduates and staff, whoever it is? Okay, this is a handful. Now, I have tailored this lecture in the interest of people who are the non-max facts guys, so excuse me. Well, this is, in my opinion, a crowd that hails from diverse specialties of dentistry and medicine. And I guess many of the people here are more in basic dentistry, interns, and probably junior doctors and maybe a couple of specialists. So I said, I sort of tweaked the title a little bit. I said I will change it to this title, because I said, if you're talking about clinical disease and less, I thought I would give you an insight into what orthopedic surgery is all about. Now, this is the title. It talks about a little bit of the science and art of orthopedic surgery. And I changed this title for a reason, because I thought there is no virtue in talking about, what should I say, the technical jargon or the nitty-gritty of the nuances of orthopedic surgery, because most of you here are not going to practice orthopedic surgery. So I said, it is something that needs to be sort of overlooked in the sense that you have an overview of what this orthopedic surgery is all about, besides talking about the nitty-gritty of things. So, this is what I said, and when we say changing faces and changing lives, and I hope at the end of this lecture, I should be able to enlighten you about something about orthopedic surgery, so that we carry some words of orthopedic surgery and know what orthopedic surgery is all about. What do you understand by orthopedic or craniofacial surgery? So, I want to know this. Well, now orthopedic surgery or craniofacial surgery cannot be used synonymously. Nevertheless, this is something that deals with the facial skeleton. And orthopedic or craniofacial has something that deals with facial skeletal surgery. Now, what's the difference? Essentially, both are facial skeletal surgery, but if you look at orthopedic surgery, it deals with the lower half of the face, and craniofacial surgery deals with the upper half of the face. So, when we are dealing with orthopedic surgery, that means we're dealing with dentofacial deformities, and if we're dealing with craniofacial surgery, we're dealing with something that's beyond dentofacial, it's craniofacial deformities. And that is something that is about craniofacial syndromes and whatnot. So, that's out of purview of this 30-minute lecture, so I thought I would breeze through said, craniofacial surgery is pretty diverse, extensive, and I don't think I'll deal with that in this lecture, but nonetheless, I thought I'll just skip a few slides for you to see what craniofacial could be. And this is a post-traumatic deformity where he's broken his forehead, nose, and orbital complex. And you can see that before I say something, the pictures in the entire series of the lecture, you will see on your left-hand side is preoperative, and on your right-hand side is post-operative pictures. So it is just for a comparison. So this is a craniofacial deformity post-traumatic, corrected, and you can see how his forehead, nose, and cheekbone of the zygomatic bone is corrected. And that's seen in a different views. This is a very funny disease called the polymetric syndrome. And this is something that you cannot correct with one shot. You probably require multiple procedures. And this is a chart with a variety of procedures that he has gone through, and that's seen in the different views. Now, we come back to orthodontic surgery. So what is orthodontic surgery? One intention here is to tell you why, when, and how, and what you could achieve with orthodontic surgery. That's it. Nothing less. So, orthodontic refers to jaws, and orthodontic surgery is nothing but jaw surgery. Now, jaw surgery, since orthodontic surgery involves moving the jaws, it deals with, as I said earlier, deals with the changes in the lower half of the face. Right? So it's orthodontic dealing with dentofacial deformities. So as I said earlier, it's a restructuring and relocation of the jaws. Mind you, you'll be supposed to know that all this can be done transorally. You can actually do all procedures through the mouth, and mainly you can bring substantial changes to your face by doing surgery through the mouth. So there are no external facial incisions. And that's the beauty of orthodontic surgery. So, in the process of orthodontic, you need to know a few things. You need to know what the various procedures are and what you can achieve with orthodontic surgery. Now, this is a surgical option. This is just diagram to history of thought. But you can do surgery on the upper jaw, you can do surgery on the lower jaw, and you can combine these procedures. There is a variety of procedures that you can do, and this is just to list out the number of procedures that can be done. In the maxilla, you can do segmental osteotomies, you can do L4, L2, and 2 osteotomy. In the mandible, you can do again segmental osteotomies, you can do genoplasty, and you can do a sagittal split osteotomy. Now, the procedures can be done in isolation, or these procedures can be combined. And you will discover how one can actually bring about phenomenal changes to a face by just combining these procedures. Right? So, there we are. What can you achieve with orthodontic surgery? Just have a look at these pictures, and you know what can be done with orthodontic. This is pre and post. I'm not going to delve into details of what has been done, but then you can appreciate what the changes are with orthodontic surgery. And this is the goal. That's another goal with orthodontic procedure. Chin protrusion, maxillary protrusion, mandibular protrusion, and so on and so forth. This is what you can see. The kind of changes that you can bring about with procedures like this. And these are some of the procedures that combine the chin, the jaw, the upper jaw, the lower jaw, so on and so forth. This is going to be an array of pictures more than a technical jargon of orthodontic surgery. I just want you to appreciate, and I will speak to you a few components of orthodontic surgery that are important for embarking in this pursuit of orthodontic surgery. Now, the next question is when and why. So, you may have patients with what we call mandibular prognatism, maxillary prognatism, retrognatism of both the jaws, combination of these two asymmetries, and so on and so forth. And this is something that you can address with orthodontic surgery. These are some of the procedures. These are the combinations of things that you would probably encounter: prognatism, retrognatism, and combinations of asymmetry, and perhaps you would see post-traumatic jaw deformities as well. Now, let's look at it from a different perspective. This is called the dish face deformity. What do you call it, the dish face? You can see those lines. They are concave faces. So a concave face is a deformity. A convex face is also a deformity in a sense. So this is a concave face. You can see the magnitude of the problem could be from minor to very severe, actually in some cases. And the concavity of the face is a consequence of those three things that you see on the right. It could be maxillary protrusion or protrusion or a combination of these things. So you get what we call a class 3 skeletal deformity. Now, you will see a few cases where we have done class 3 skeletal deformity correction, and these are some of these patients where you can combine both the upper jaw and lower jaw procedures, and this is what you see as a result of movements of either of the jaws or both of them. And this is a class 3 skeletal correction of the various magnitudes, minor, moderate to severe. And this is a very severe one. That's some of our videos. Well, we now come to the next, what we call the class 2 skeletal deformity. Now, what a class 2 in our terminology is a concave face. Sorry, a convex face. So this is a convexity, and the convexity can vary. It could be a mild convexity, and it could be a very severe convexity. So you can see a convexity can arise when the component of the center is protrusive and the one below is retrusive. So it could be a retrusive mandible or protrusive maxilla. So it could be also a very severe retrusive mandible, whereas the maxilla is normal. So you can get a convexity like this. And I will show you a couple of patients where the correction of a class 2 skeletal deformity or a convex face, where you have to sometimes move the mandible forward, essentially one number of times the mandible forward, but at times maybe the maxilla as well, which where you have to move it backwards, and that's a related issue. We can move the maxilla back, partially the entire maxilla as well as part of the segment back as well. So this is what you see as a result of skeletal convexity correction. And this is how in the different views, and that's the profile. This is one of the most severe convex profiles that I've ever corrected, and this is not with distraction, this is just with orthodontic surgery. And this is what the series in the frontal profile projections. That's some of the big shots. Very severe convexities of the face can be corrected with orthodontic surgery only. At times we have to resort to distractions, but then it could be resort to extreme sedation. However, having said that, I think you can still manage extreme convexities with conventional orthodontic surgery. And that's the goal of different views. We come next to what we call facial asymmetry. Now, when we talk about asymmetries, there are a host of asymmetries that we can see. Most of the times, the asymmetries that we see are essentially due to a mandibular problem, and these asymmetries occur due to either a condylar hyperplasia or condylar hyperplasia. It's for you to decide what the problem is, but nevertheless, the correction goes with the diagnosis. So you have a facial asymmetry. Here you see condylar hyperplasia or hyperplasia situation, and these are much more trickier to correct than the ones you saw earlier, the class 3 and 2 deformities. So these are much more trickier. This is an asymmetry. Obviously, you apply the same principles of orthodontic surgery, but then at times you have to do what is called some sort of shading of the bone and things like that. But this is asymmetry corrections. This is a condylar hyperplasia. And again, a twisted face. What happens with the condylar hyperplasia or hyperplasia? The maxillary jaw also gets tilted. So this is what we call cant. You get a cant. So when you get a cant, assume that you deal with only the lower jaw, you have to deal with the upper jaw as well. So most of the times, if you're dealing with an asymmetry, you have to deal with both the jaws, not the single jaw issue. And this is what you see as asymmetry correction. Now, extrapolating your skills of orthodontic surgery to correcting shapes of faces. Now, believe me, if you look at faces, there is a definite inclination to a face. I'll come to that in a minute. And this is the short face, long face, round face, square face, whatever. Believe me, a short face can be lengthened, a long face can be shortened, round and square can be made oval, so on and so forth. So, let's look at the facial forms. Now, these are some of the facial forms. Essentially, the basic facial forms, the round, square, and oval. The square being more masculine, the round being more boyish, and the oval being more appreciative and more sought out and desired one. So, most of the times, we convert square and round faces into more oval faces than the other way. So, we come to the next question, what is an angle profile? Now, an angle profile, I think there's so much science to what an angle profile is all about. I'm not going to delve into the details of these things, but nevertheless, there is something called facial measurements, anthropometric measurements. You need to know all this. There's something called the vertical fits, the horizontal curves, the profile, and so many things to this. I'm not going to the details of these things, but this is almost an ideal profile you can see. And the frontal and lateral projections is the oblique projections as well. There's something called an OG curve and so many things. I'm not going to the details of these things, but this is just to illustrate a point that you need to know what an ideal profile is before you embark on anything to change in faces. Now, this is the picture you saw earlier. This is the chap who had a short face, and he wasn't happy about it. And this is what you see, basically lengthened his face because his spine isn't interesting. He looks pretty pathetic on the profile. And that's his frontal projection. And that's his profile. You can look at this profile and what an ideal profile I was talking about, because there are certain parameters that you need to follow, and you need to get that into an ideal profile. And this is what an ideal profile perhaps is, because if you see on the right, I'm sure anybody here will agree that he would be better on the left than on the right. Yes, am I right? Other way around. Yeah, it's the other way around. So I'm sure he looks better on the right than on the left. So that's how he is. So look at his smile. Look at his projections. Look at his lips. Look at the midface contour, circumferential contour, the ornamental distance, the chin projection. There's so many things that we can talk about. Anyway. So these are all short faces that are lengthened. You can lengthen these faces. There are several ways of doing it. I'm not going to the details of that, but this is what you can see. A short face turning into a long face. And this is in the different rooms. Again, a medical student of Bandanawaz a long time ago, I authored perhaps 20 years ago on this guy. I lengthened his face, you can see his profile, and that's him. You can see the projection of the chin and the contours, and that's him pre and post. Now, when you have a longer face, essentially you have patients with a longer face who always have what we call a dummy smile, and also they have what is called lip incompetence. Those are essentially cases which are longer, skeletally, but also they don't have a problem with the soft lip, they're a little short. Nonetheless, Nevertheless, it is for you to assess what the problem is, because lengthening the lips is much more about to task than doing orthodontic surgery, believe me. You can lengthen the lip much more than what you can, but then you can correct this very small shadow in the face, and you can get this kind of a profile, and look at that. The lip incompetence also could be due to a retrognatic chin, because the chin is too far below the lip, lip fails to meet the upper lip. And this is what you can get with a shortening of the face to an extent, and that's with the different views. And here's the square face. This is the square face. This is a square face, made more oval, and you can see that I changed the jawline as well, so you can see the jawline, and that's with different views. Another square face looks pretty narrow. That's essentially because of the lengthening of the ratio, lengthening of the face, it renders it narrower, and that's seen in different views again. Around the face, made more oval, you can see that in the different views, and that's in post, the another patient. Around the face, made more oval. Look at this, much more squarish, not particularly appealing. And you can see it in the post-operative picture, and that's from pre-post. Orthodontic surgery in cleft patients. You can obviously do cleft surgery, you can do no matter what, but then you can always have cleft facial deformities. And these cleft facial deformities are essentially because the maxilla in cleft patients fails to grow, and you inevitably end up with what we call a class 3 facial deformity or concave face. And these are much more trickier than what I said earlier, but recently, I think you need to be really go around and doing things for these patients, a couple of surgeries, maybe soften hard tissues, but then, these are 2 patients, probably I can show you some 3 cases. This is preoperative, and that's the occlusion. That's the pre and post-op shots. That's bite on the extreme left, preoperative, immediate post-op, and late post-op. And that's before and final pictures. Now, similarly, I can show you one of 3 cases of cleft corrections. So another patient with cleft facial deformity, you can see the change in the facial profile. And that's in the different views. That's his occlusion for pre-post. Still in the face of orthodontic treatment. And here's another patient. Pretty bad skeletal facial deformity, secondary to clefts. And this is where that's an occlusion. This is one of the longest reverse ridges that I've ever corrected. And that's the reverse ridge that you can see in the lowest picture there. That's her with probably 1 or 2 or 3 procedures, pre and post. That's the profile that you can achieve. That's in the different views, rehabilitated completely, and that's in the final pictures. That's the occlusion you can see, which is below. Radiograph separations, pre and the final shots. So this is what you can do with orthodontic surgery even in cleft patients, believe me. Now, although it seems so easy when you saw all these pictures, there is a science to what orthodontic surgery is all about. So what I'm going to do is not give you a technical jargon, but nevertheless, I tell you what it involves, because orthodontic surgery involves 2 specialties to a large extent, by and large, orthodontics and surgery. You may have to do orthodontics in most, more often than not. Orthodontics is a part of orthodontic surgery as well because of the concept of occlusion that plays a large role. Because you cannot compromise function at the cost of an aesthetic result. So function comes first, and hence orthodontics is also important in most orthodontic surgery patients. So all these concepts need to be understood before you embark on this pursuit. The concept of occlusion, the most important. Number 2, somebody that the team dynamics just classification, how many imbalances, the numbers, the measurements, the anthropometrics, the third, the fifth, and blah, 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 and so many things. Saphanometrics is also important. Anthropometrics, as I said, and orthodontics goes without saying. Now, there are two concepts on orthodontic surgery. The pictures that you've seen over the past few minutes is something that is dealt with a conventional approach, what is called a conventional approach, and a surgery first approach. There are two approaches to orthodontic surgery. Now, what is, if you need to know what is conventional approach? Now, conventional approach, orthodontic surgery is performed after a simple. Orthodontic surgery is performed after a phase of orthodontics. So, orthodontic surgery is an interim phase of the orthodontic phase. So, you start with orthodontics, surgery, and you complete it with orthodontics. That is a conventional approach. And what you saw in the pictures, most of them were in the conventional approach. Now, what I'm trying to do is show you what can be done with surgery first. Because with the conventional, the duration of treatment runs to about 23 years. Whereas with orthodontic surgery first, the case can be completed and treatment can be completed in less than a year or maybe sometimes 18 months. So this is about conventional approach. This is about surgery first approach. What do you do surgery first approach? If required, start the patient up with orthodontic braces, surgery straight away, and carry on with the orthodontic phase over a period of time, which could be 6 to 12 months. So what, in essence, you are doing is bringing about drastic changes to the face immediately, where the patient is very happy. Number 2, you are eliminating pre-surgical orthodontic phase. And 3, unfortunately, you're taking a short period, and most patients, if you subscribe to this, patient will subscribe to this as well. But, there's a big but. You need to know which one fits into what. Whether you can go in with conventional or whether you go with surgery first. It's something for the clinician to decide. As I said, it takes shorter time with surgery first, and this is to tell you the technical jargon of what orthodontic surgery is all about. You need to do all these things manually. It's not taking the patient to the table and just operating. You need to study the case. You need to do all these things. Something like supplemental tracings and, prediction tracings, mock surgeries, reconstruction, blah, blah, blah. There are a few steps to all this. So you need to do all this irrespective of whether it is conventional or surgery first. The steps remain the same because you need to do all these things, whether it is surgery first or conventional approach. So this is just to boost through a few slides to tell you that there is orthodontic surgery not as simple as you think you saw. Right? So this is what we call, we need to do some normal surgery and blah, blah, blah. And this is transferring the records and making it spins and so on and so forth. Now, I will show you a couple of patients with an application of the surgery first approach. And you can see a variety of patients there. Beginning with the first one, a terrible gummy smile. Terrible is not the word. So this is a terrible gummy smile. That's also a gummy smile with a longer face, a square face, and asymmetry. So let's see what we can do with this. And this is mandibular retrusion. Now this is a patient who went in for surgery first. And this is what you can see. That's his bite. I'm not going to the details of that bite. I think it's a class 2 deep bite, closed bite, whatever you call it. And that's him. From the top to the bottom, you can see that is where he started. That's where he ended with surgery first. That's the interim phase in between where we did the surgery and also saw the, and you can see the occlusion there. And these are the ribs. A joint between the surgical line. These are the ribs again. That's some pre and post. That's some beautiful news. Okay, let's look at the skeletal class 3. Let's look at the skeletal class 3. Now again, Passing the different views. Passes occlusion from where we started and where we ended. That's it. So you can see that the occlusion is almost perfect. Those are his radiographs. Here's another class 3 skeletal. The one you saw earlier was what we call a high angle class 3. And what you see here is what we call a low angle class 3. This is a huge chap, really 6 footer, who needs facial elongation as well. So this is a chap who had a bite like that, and a squarish face, elongated, but was grafted, and that's seen in the radiographs there. That's some immediate post-operative views. That's how it looks. That's the profile. That's his occlusion from the left to the right. That's his occlusion that is finished in perhaps less than 6 months. That's his final views. Now the complication is symmetry. This is a consequence of condylar hyperplasia. And you can see the tilt that I was talking about in the first picture. But that's the tilt of what we call the occlusion. That is, the entire maximum mandible is tilted downwards on the right. So that's seen in the different views. This is a dual jaw osteotomy. Look at his bite. There's partially a lateral bite as well. And you can see the extent of asymmetry. Look at the X. You can see the mandible is going beyond the fill. And in the pre-view as well. What you can see here. And that one here. So that's his occlusion from the top to the bottom that you can see full, strapped up, immediate post-surgery, and that's in family. And these are the radiographs. You can see you can actually appreciate the grain of the mandible that has been corrected because it is more symmetric here. And that's the radiograph. You can appreciate the extent of asymmetry that has been corrected. Mind you, there might be limitations for various reasons, but then this is what could be achieved. This is what you see in the radiograph as well. A pretty symmetric X, and that's seen perhaps about a couple of months later. That's seen in the pre-post shots. That's seen in the final views with the occlusion, with the completed orthodontics. Here's a severe smile that you saw at the beginning. Look at this girl, severe occlusion, severe incompetence, absolute close bite, reducing mandible, excessive overjet, so on and so forth. Look at the profile. Now, this is the occlusion. This also is surgery first. You can see the occlusion, the top, strapped up, and post-surgery. These are the radiographs. It's a dual jaw osteotomy. That's her. In the final pictures before and after, this is what we can achieve with the dual jaw procedure. That's the profile. That's the before and after. That's the final pictures. So, another face, a long face again, unlike the previous one. A long face, reduced chin, double chin, looking competence, gummy smile, whatever. It's all there, anterior to right. These are the pictures strapped up. Surgery immediately. Pictures of the occlusion. Immediate surgery, probably in 3-4 weeks. And that is the occlusion where it started on top. That's the final occlusion. That's all the final shots, before and after. And that's how she is. You can see the pre-op shot on top. And these are the final shots, and that's the final occlusion. So, what I would like to say is orthodontic surgery is definitely a challenging specialty of maxillofacial surgery. Now, it's not something that you can embark on without having adequate training. You need to familiarize and learn the concepts of diagnosis and management. You need to know the nitty-gritty of things before you embark on this pursuit. Know the techniques and procedures. Get yourself trained well before you can actually do these procedures. I think diligent planning and diligent execution is the key to success in any sort of area of surgery. Nevertheless, I think changing faces, changing lives by orthodontic surgery is a possibility. Being that it's a precise science, it's not something that you can do just like that. So it's a precise science and an art where there is, I believe, no scope for ambiguity. I'd like to end this with a quote by Albert Einstein, which says, "The intuitive mind is a sacred gift, and the rational mind is a faithful servant." Read it very carefully. When you have created a society where only a servant has forgotten the gift, discover the gift in you, the ingenuity in you. You have entered the science before you apply that. Thank you for your attention.
Thank you, sir. Thank you for a wonderful presentation. Any doubts? Rather, any queries? There's everything to show. Thank you. It's a privilege, sir, to be a chairperson of your talk. You are one of the pioneering maxillofacial surgeons, and you have brought the maxillofacial surgery to a new level. This talk was not a real talk. It was a magic show. You are showing you are Jadugar now. You are showing the ugly faces turn into a beautiful face, and definitely those beautiful faces, definitely they might have changed their lives. Your title just justifies that. The changing faces, changing lives. Thank you. Thank you.
Thank you so much, sir, for this beautiful session.
One thing, you are still a Jadugar with the hidden secrets. You are not shown how you have done it. For that, you have to visit your center.
Sir, pleasure to have you in Morocco.
Hello. I think we'll have a session on the how to do it another time.
Yeah, as you said before, it is not a lecture that is to be covered in half an hour. We need at least 1 or 2 days. Surely we'll have an interdisciplinary speakers, one workshop here in our town. Thank you so much for coming to our town and showing such beautifully displayed cases of yours, which will rather promote our postgraduates and the new clinicians to convince the patients, sir. Thank you so much. Thank you, sir. Now I would like to request the chairpersons to felicitate Dr. David Toro, sir. Thank you, sir. And to felicitate our chairpersons, I would like to invite on stage Dr. Amol Patangi, sir, Professor and Head of the Department of Psychiatry, Faculty of Medical Sciences, KBN University. Thank you, sir. Now to the audience, should we have another lecture or should we have a lunch break? Lecture? lecture? Lunch. Let's have a lunch break and assemble again at 2:15 in the hall. Thank you. In hand, we'll make sure you get it in the next call. Today's scientific session, I would like to invite on stage Kenya sir, Professor, Department of Oromaxillofacial Surgery, Al-Badr College, and also Dr. Tasweem Ustad sir, Reader, Department of Oromaxillofacial Surgery, Al-Badr College. So please come up on the stage. And to introduce our speaker, I would like to request Dr. Juhi Shabnam ma'am, Assistant Professor, Department of Dentistry, Faculty of Medical Sciences, KBNU.
Good afternoon, everyone. I would like to introduce our next dynamic speaker, Dr. Girish Khaja sir. Sir is an associate professor and a fellowship guide at RGHS recognized Sanjay Gandhi Institute of Trauma and Orthopedics, Bangalore. He has finished his MDS in maxillofacial surgery and has done his fellowship in facial aesthetic surgery and medicine at University of Greifswald, Germany in 2015. As a consultant maxillofacial surgeon with over 15 years of clinical and academic experience, he has previously worked as an associate professor at Inaugural College of Dental Science and now is a consultant facial plastic and hair transplant surgeon at Siloam Hospital, Bangalore, Vijayashree Hospital, Rottigiri and Jignan, and Venkateshwara Multi-Speciality Hospital, Adugudi. I please welcome sir to the stage.
Good afternoon. Thank you for your introduction, Dr. Zoe. Today I'm going to present about challenges in management of soft tissue injuries, maxillofacial trauma, and post-animal bite. So there are two challenges here. One is the challenges of management of soft tissue injuries, and the one more important challenge is a post-lunch presenting any presentations. People will be little hyperglycemic. So it's a real challenge for me to, keep people awake. So since the audience crowd over here, I felt they're highly trained professionals with a medical background. So I don't want to explain in detail about the suture techniques. Rather than I just wanted to highlight the suture techniques implemented in different types of severity of injuries. Any scars over the face, so that leads to disfigurement, maybe the patient will end up with, becomes a social stigma for the patient and also a cross detrimental effect on his personality. So the operating surgeon, I can start this. The operating surgeon, as a goal, we should have a goal to minimize the scars and also to give better aesthetic results and also to restore the normal functional restoration of the patient. So the operating surgeon should be having an initial management, should have a well-equipped with a simple primary suturing, and if the situation demands, the operating surgeon should also know how to do skin wraps or flaps to give better aesthetic results. Before starting my actual presentation, I just wanted to broadly classify what is soft tissue injuries. What I personally feel is soft tissue injury can be classified in two types. One is any soft tissue injury over face with no tissue loss, and one is with tissue loss. So the final outcome, the aesthetic results of soft tissue injuries is not only depends upon initial management or a professional experience, but also depends upon its severity. See, in this case, though the soft tissue injuries were so extensive, but there was no tissue loss, so we could achieve better aesthetic results. Let us come to the next slides. Here, the severity, the soft tissue injuries, there is an extensive tissue loss was seen. So, irrespective of whatever we did, the possible treatment like a local flaps, however you switch them, a graft, and with the help of our senior professional expertise, whatever possible treatment what we did it, end of the day we ended up with unsatisfactory outcome. So what I wanted to conclude is, any soft tissue injury, the injury over the face is not only depends upon our professional experience, it also depends upon the severity of soft tissue injury with or without tissue loss. So let me start with conclusion. Conclusion is a small blunt trauma caused by blunt trauma, and if you start noticing any of the small hematomas, there is no need of any surgical intervention required from our side. Just wait and watch and observe. Whereas you can see the second photo here, you can see a huge hematoma collected over the tongue. You can make it there. So this leads to any breathing difficulties or swallowing issues to the patient. So this requires a definitive surgical intervention of the from a surgeon to evacuate the hematoma and restore this functional restoration, like a difficulty in breathing has to be solved. Coming to abrasions, here everybody knows the first degree and second degree abrasions. One is the first degree is involvement of epidermis, and second degree abrasions are involvement of dermis. So in any injuries, abrasion wounds, first degree or second degree, or if the abrasion is involving only epidermis or dermis, doesn't require any of surgical intervention much. Just it requires a petrolateral gauze dressing or bacteria dressing. And end of third week, from the end of 21 days, we can just minimize the scar by using the anti-heparin drugs or anti-heparin based ointment or collagenase based ointments. Whereas comes to the third degree, abrasion wounds, which is very deep into the dermis, can be managed with artificial skin grafts like collagen grafts. Some people try to use even skin grafts, but I don't personally use skin grafts because two reasons. Skin grafts has a disadvantage of mismatch in color. That's one thing. Second thing is donor morbidity side. Morbidity will be seen. So in order to avoid that, I personally use usually collagen grafts to treat any third degree abrasion wounds. And the advantage of collagen grafts is it acts as a biological dressing, prevents thermal contraction, and releases the human growth factor, which helps in re-equilibration of the skin, so that we can achieve very good results, highly aesthetically acceptable results in fact. So if you see any of the abrasion wounds, don't take it lightly, go for the collagen grafts, and you can get good results to the patients. Coming to the puncture wounds, a very tricky one to handle. Usually puncture wounds looks very smaller from outside, but there will be possible injury to the underlying tissues like ducts or vessels, or sometimes the glands will be injured. So in this first case, there is an injury to the duct, thyroid gland duct. So we are able to identify the thyroid gland injury, duct injury, and we suture the duct by using the non-observable 8090 sutures and using the magnifier loops, and then layer by layer suturing was done. And in the second case, there was an injury to the thyroid gland, so we sutured the thyroid gland, and then we sutured layer by layer, and compression bandage was given, so that in order to prevent any salivary fistulas. So any puncture wounds is just not only suturing of a skin suture, layer by layer suture also. Other than that, please rule out any possible injury to the underlying structures. Coming to the evolution, any wound which comes out like a wound flap, you can see this has been elevated like a flap here. What we usually do is just we do a suturing. But just doing suturing, it doesn't help out because there is a larger hematoma connects between the flap and the wound. So what happens, it leads to a lot of scar formation. So along with the suturing, after suturing, just put a minimal dressing using a dynaplast or a simple microboard tape that gives a very better results. You can see that the wound flap is adapted to the underlying tissue so that the scar will be minimized. The same thing, there was a wound flap which from the nose, it was sutured back, and the minimal pressure dressing was applied to achieve better aesthetics results. Next comes erosion, loss of tissue. Any loss of tissue or face can be managed in three types. One is doing a primary closure, Second thing is skin graft and local flaps. So in this case, there was a loss of tissue noted on the forehead. So I decided to go for a primary closure. I didn't consider any of the local flaps, or I didn't consider any of the grafts. Only reason is this is a highly anesthetic region where the tissue can be undermined and can be pulled out to suture it. And also, on the forehead, there is no functional structures like eyelid or upper lip. It's not there, so that even if you do a primary closure, better anesthetic results can be achieved. Now I see next slide. This slide was supposed to be previous slide, but anyway, by mistake it has been come here. Why I wanted to add this slide is, whenever I mention to my colleagues or any of my professional colleagues that I'm doing a suture and I'm coming, just a suturing will come off. It's not like that. Suturing is not only a cosmetic, it's a life-saving procedure. So don't take it anything lightly, even if it's a small suture or a big suture, life-saving it's going to be a life-saving procedure sometimes. So in this patient, our anal fractures and extensive soft tissue injury, which was causing a lot of bleeding intraorally, and patient was able to, because of aspiration, he had loss of consciousness. We did a tracheostomy and we fixed the anal fractures, and we were able to close the wound. Cosmetic was not my priority in this time, so I did a loose sutures so that if there is an infection occurs, so that I can overcome the infection. So it has become a life-saving procedure, and patient is doing well. Hopefully next presentation, whenever I get a chance, I'll get a post-operative pictures. And loss of tissue, you can see the continuation of loss of tissue here. See, there is a loss of tissue noted in the forehead region, and loss of tissue noted over the lateral to the orbit here. So, but still, last previous slide I told no need of any flaps required for forehead to cover the forehead if there is any loss of tissue. But here, in this case, I consider to do advancement flap because considering his age, because what happens sometimes the wound contracts across, you can't raise his eyebrow, and the face will become a mask kind of face. So I just wanted to restore his facial restoration also along with cosmetic. So what I did is, I did a modified advancement ficus flap. This is a ficus flap. I advanced it, and this is the transal flap, interposition transal flap, so that we can achieve a better aesthetic results over here, so that the patient didn't have any issues with closing his eye, especially on the right side eye, or raising his eyebrow. And coming to this picture, there was a loss of 1/3 of a lower lip here. So if I would have sutured, if I would have considered a primary suturing, what would have happened is, the mouth would have become constricted, contracture would have occurred, and patient would have not able to open his mouth, or speaking would have become difficult. So in this case, what we did is abyss flap. Most of the time, this abyss flap will be used in oral cancer reconstruction or post-operatively to reconstruct after post or oral cancer excision. So we took the flap, advanced the flap from the chin region and extended towards the lip. Though cosmetically it is little compromised, but still the patient can open his mouth, he can speak nicely, the pronunciation is good. So rather than cosmetic, here my concentration is more towards the functional restorations like speaking, opening his mouth. So we are able to achieve this functional restoration. So here, a very tricky case, there is a big loss of tissue noted around the anterior region of the neck caused by a bear attack. So here in this case, if I were to consider for a primary suturing, the neck would have become tilted towards anteriorly, and patient would have not able to move his neck at all. So here, rather than cosmetically, I wanted to achieve a better functional restoration. So what I did is, we took a height-free flap, anterolateral tie-free flap, and we are able to close the wound over here, and the patient can move his neck thoroughly, and the functional restoration is achieved. So each cases are different. Sometimes, as the previous slide showed, local flaps, the other primary closure, and here the free graft. Sometimes, here you can see in this case, the scalp is totally exposed, but complete skin graft. So skin graft also can be considered if you don't have any other choice. And bone can't be exposed and laid off like that. Coming to the lacerations, so you can see a small devitalized tissues over here. So regardless of devitalized tissue, whether it is an upper eyelid or upper lip, everywhere it is, we have to excise conservatively. See, this devitalized tissues was excised completely, and underlying the tissue achieved primary closure to achieve better aesthetic results. Better in the sense acceptable aesthetic results. If I would have not excised that devitalized tissue, definitely it would have become necrosis, and the results would have much more bad compared to this one. And one more technique to reduce the scar. If you see, so most of the time because of abrasion wounds, nowadays it has been less in, especially in Bangalore city because of usage of helmet. But I don't know how the people will use helmet here, how far, effectively they use it here. So I think you in your city, I think you might get a lot of cases like this. See, in these type of injuries, you can see a parallel skin lacerations can be seen. So instead of suturing over here and making to here, making it to 2 or 3 parallel suturing, excise this intervening skin bits, make it like a one hand, suture it so that the minimal scar will be restored, and aesthetically we can get good results for the patient. And if you see any wounds with a ragged border or uneven wound margin, and it's not a simple cut, simple straight cut, go for a simple interpret suture with a elevated margin that gives a very good results at the end of the day. You can see this. There was a wound margin was very severe, ragged border, and it was not even, but we could have managed to get this aesthetic results, we can manage with a simple interpret suture. If you see any clean cut, straight cut wound, go for subcuticular sutures. Subcuticular suturing was done to get a better aesthetic results for the patient. One more is key suture. Before doing my fellowship in aesthetic surgery, if I would have got a suture like this, what I would have done is I would have started from one end and I would have come to like this. Or this wound, I would have started from down one end and I would have come to the other end. That's not the way to do, especially in the functional structures like upper eyelid or upper lip or eyelashes, lower eyelid, those type of cases. Thing is, we should do a key suture first. What is key suture is, whenever you see a wound like this, approximate the upper border of eyebrow, lower border of eyebrow, match the eyebrow, then go for the suturing by the other ends. So that is known as key suture. And in upper lip, match the vermilion border first. Suture the vermilion border, match the vermilion border, then rest of the things lacerated wound, you can suture it off. So this is known as key suture. Key suture is a very important point whenever you are handling functional structures like eyelids or upper lips or lower eyelids or any functional structures. And this can be seen on lower eyelid, key suture was given, match the gray line and lash line in the line. This is the match of gray line and the lash line, and rest of the suturing was done so that to give better aesthetic results. And these are the few case pics where we match the vermilion border and to get a better aesthetic results. So key suture is a very important point whenever you are in any functional structures like upper lips or eyelids or lower eyelids. And some pictures which shows again the vermilion border of upper lip was matched to get a better aesthetic results. Coming to the ear suturing, see most of the people what we use for a facial suturing is anesthesia is xylocaine with adrenaline. But whenever we are handling a ear suture, please never use anesthesia with xylocaine with adrenaline, because first of all the cartilage is avascular, and if you give a local anesthesia xylocaine with adrenaline, the chances of getting necrosis of cartilage will be more chances. So better whenever you are handling the structure or any procedure near the ear, try to avoid giving a local anesthesia with adrenaline, and always use without adrenaline. And the key is, whenever the cartilage is exposed, cover the skin. Don't a loose sutures, 1 or 2 sutures, but better to avoid suturing the cartilage, cover the skin, and then the more important thing is give a burster dressing. What is burster dressing is? Once if you done with the suture, take a pad, keep it below here, above here, and just cut it with a microcut tape, apply microcut tape, so that it puts a minimal pressure and holds the ear in the position. Two advantage. One is the shape of ear also it's regulating. Second thing is the skin will get adhered to the cartilage, so that any anatomy will prevent it and they will get a better aesthetic results. And these are the few case picks which here suturing was done using a burster dressing. And coming to the extensive tongue repair. Whenever you have any tongue lacerated at home, just don't do suturing and go off. Because the tongue is, if there is a post-operatively, if the tongue edema increases, there are chances the tongue will fall back or it leads to breathing difficulties. So whenever you do any extensive, not for 1 or 2 sutures of tongue, I'm talking about the extensive tongue suturing. If you do an extensive tongue suturing, take a bite from the neck, from the tip of the tongue and pull it out and keep it for 6 to 8 hours, so that the patients come, if you manage the case under GA, let the patient totally become conscious, or if you manage under local anesthesia, let for 3 to 4 hours or 6 hours, so that the edema of the tongue can be analyzed and then we can remove the sutures. So this previous lectures, most of the cases which I showed was most of post-trauma, but now I will come to anemia attacks. So the gold standard for to manage the anemia attacks is usually what everybody advises, or a textbook says, or academic pressure says, no suture it, just wait and watch. Yeah, that is true actually. If it's a small injury, we can wait, postpone the suture as much as possible, and wait for secondary healing and then go for a suturing. But an injury like this, you can't leave the wound like that. You have to suture it because it's bleeding. So you can't do anything. The suturing is really needed. It's mandatory now. So now, the suturing you can go ahead, but before suturing there is a medical management. You have to go ahead with rabies immunoglobulins. You have to infiltrate rabies immunoglobulins around the wound and then do the suturing. Don't get confused. Rabies vaccine is different. Rabies immunoglobulin is different. So I will explain much more in detail in the coming slides. So definitely this has to be addressed. We can't leave a wound like this. So this patient was injured by a bear, and there was a globe, everything was injured. So definitely we wanted to interfere in a more emergency way. So the patient had multiple fractures, we fixed it. And for the soft tissue, initially we covered with the skin grafts for the scalp and for the orbit region and maxillary region. And unfortunately, the skin graft didn't take up in the anterior region. So then we ended up with doing anterolateral tail graft and cover the whole face like this. Again, it's a dog bite. So according to textbooks, I can't leave a wound like this and wait for a kid to suffer with an open wound. So definitely we have to suture it. So we did a suturing with a aortic margin. You observe carefully, it's a aortic margin and very loose sutures. It was not given whenever you suture anemia attacks, injuries, always go for the loose sutures and as loose as possible and aortic margin to get a better aesthetics results over here. So coming to the medicinal management, which I was mentioning, how to manage the anemia attack. So any wound which is caused by irrespective of whether it is dog or a bear or even sometimes rabbit has been caused or cat, anything, any animal for that matter, first wash the wound thoroughly with a running water, running tap water for at least 10 minutes. Then use a soap or detergent. If soap is not available, continue washing with another couple of minutes just with the cold water. And after thorough washing the wound, dry it and apply some betadine or pyridine iodine. And you still take this has to be done immediately. If a patient comes after 2 or 3 hours or after 6 hours or after 8 hours, the same it should be continued. We start with washing the wound on the disinfectant, then irrespective of time. And as I mentioned, postpone the suture if possible, if it's a small wound, and if it's really necessary to perform the suturing, you have to infiltrate rabies immunoglobulins. I'll come back to the dose and everything. Along with infiltration of rabies immunoglobulins, now cauterize the wound caused by animal attacks, and supplemented with antibiotics, and also the tetanus vaccine should be given as usual for wounds. So this is the dose. So you will get more readily available is human rabies immunoglobulins, slightly expensive. So this can be used as 20 international units per body kg weight. What I want to say, if you get a patient 50 kgs, suppose the patient has come with a dog bite and he or she is 50 kgs, 50 into 20, it will be 1000 international units. So buy 1000 international units one, infiltrate around the wound, how do you give local anesthesia, infiltrate same thing around the wound to the depth of the wound, then start suturing it. Suppose if a patient comes to you with an animal attack with 100 kgs, so 100 into 20, it becomes 2000 international units. So the maximum dose is 1500, correct? So lacking another 500 units, international units. So what you can best do is dilute with the sterile saline up to twice or thrice. So I mean the maximum, take a maximum dose of 1500. I'm talking about 100 kgs patient. So the volume is you have to get 2000 international units. So take 1500, dilute with the sterile saline, make it 2000, and you start infiltrating. Suppose your patient ended up with a small, some 3 centimeter wound. So you have, the patient is very well built, you have 1500 international units. So you used only 800 or 600 international units. So rest, you need to discard it, give it intramuscularly straight away from the vaccine. Okay? So don't get confused again. Rabies vaccine is different, rabies immunoglobulins is different. So your rabies immunoglobulins has to be infiltrated whenever you are managing the animal attacks. So these are the general steps of wound management. I think everybody knows here to get a better results. Replace irrigation, remove any foreign bodies. As I mentioned earlier slides, exercise the devitalized skin tissue, and always suture the wound margin in a water way and multi-layer suturing. Hope this was really helpful for you people, the management of soft tissue injury, and I would like to extend my acknowledgement and a thank you to management of KBN University and organizing chairman Dr. Siddesh sir, Dean, KBNU, and organizing secretary Professor Dr. is a very good friend of mine, and Dr. Zana Muswi, Professor, Department of Dentistry, and my association state president Dr. Shivat sir, and secretary Dr. Nagarajita sir, and my institution Congenital Institute of Trauma and Orthopedics, Bangalore. Thank you all.
Good afternoon, sir. Very interesting session. It was quite informative. Especially post-lunch, it is very difficult, but you kept the audience awake.
Hopefully, sir. No, it's very difficult actually. It's easy to pre-lunch because because of hypoglycemic, they'll get irritated, they'll walk away. The hypoglycemic is very difficult. They'll be sleeping. They won't walk away also. You won't control whether they're interested or what.
They were attentive. I saw that. It's very informative session, sir.
Thank you. Hopefully. Thank you, sir.
Respected delegates and audience, good afternoon to everyone. It gives immense pleasure to witness this hypothetical galactical celestial event of glittering stars of oral and maxillofacial surgery descending upon this small city of Gulbarga. This has been possible because of the KBN University and the efforts of Dr. Ali sir and his team. With the, Dr. Neel Kamal sir, my guru, my master, he is present in the audience. With this permission, I want to quote this saying that nothing can be done. Nothing can be done until we accept it. The toughest fight has now begun. People see things as they are and say why, but we dream things that never were and say why not. And here the we represents all the oral and maxillofacial surgeons, especially these glittering stars of oral and maxillofacial surgery. And for your efforts, Girish sir, I think this line summarizes. The saying goes, try for perfection and you will settle in excellence. I think you have done all your cases on this basis, sir. And for the budding doctors, dentists who are present here, if they had a dream of becoming an orthopedic surgeon or a plastic surgeon or an onco surgeon, I think you should seriously think upon taking up the stream of oral and maxillofacial surgery to fulfill your dreams. And with this, we thank you so much for your beautiful presentation, sir. You began with the classification of soft tissue injuries, and you ended up with, with such good results with such complicated cases, sir. Thank you so much, sir.
Thanks a lot. Thanks a lot for your encouraging words, sir. Thank you.
Thank you, sir. Now I would request the chairpersons to felicitate sir. Thank you, sir. And now to felicitate the chairpersons, I would like to invite on stage Dr. Shilpa Pradhan Madam, Professor and Head of the Department of Microbiology, Faculty of Medical Sciences, KBNU. Thank you, ma'am. Thank you, sir. Now on to the last session of today's conference, the last lecture. I would like to invite on stage the chairpersons, Dr. Anunya, sir, Professor, Department of Oromaxillofacial Surgery, ESI Dental College. Dr. Ashwin Shah, sir, Professor, Department of Oromaxillofacial Surgery, HK Dental College. Dr. Nand Kishore, sir, Professor, Pediatric Surgeon, Department of Surgery, Faculty of Medical Sciences, KBNU. And to introduce our speaker, I would like to request Dr. Vikhar Ahmed, sir, Associate Professor, Department of Dentistry, to introduce the speaker.
Thank you, Dr. Irfan. Good afternoon to all. It is my immense pleasure to introduce Professor Dr. N. Srinath, sir. He completed his MDS from A.B. Shetty Memorial Institute of Dental Sciences, Bangalore in 1995. He had done his fellowship in dental surgery from Royal College of Surgeons, UK in 1997, and a fellowship in aesthetic medicine from American Academy of Aesthetic Medicine in 2012. Sir is also a member of IDA and American Association of Oral and Maxillofacial Surgery. He is the director of Mallige Smile Foundation and member of Hyderabad Cleft Society. Sir is also a Senate member of RGHS and faculty to train postgraduate students to the government of Bangladesh, government of Ethiopia and Romania. He is also the honorary president of Karnataka State Association of Oral and Maxillofacial Surgery. I now welcome sir on to the dais.
Good afternoon, everybody. Thank you, Doctor, for the kind words. I think it's a great honor to be here in this institution named after the 14th century Sufi saint. I'm really honored, and I thank Dr. Ali for inviting me and the respected chairpersons. Can I proceed with my lecture? Malformations, management by the maxillofacial surgeon. To go forward is right. So I think it's an asset to have an oral and maxillofacial surgeon among the medical fraternities, especially in a medical institution like what we have here, the Khaja now in the medical college. The oral and maxillofacial surgery is the most exciting thing which is happening today in the dentistry. The maxillofacial surgeon can help you to handle the trauma cases. He can help you to handle the congenital deformities. He can help you to handle the skeletal deformities. He's also a part of the team in sleep apnea. He's a part of the team in reconstructive surgery. He's part of the team in pediatric surgery. So to have a maxillofacial surgeon, it really completes the whole cycle of management for the patients. So I would request every medical colleges in our country to have a maxillofacial surgical department. Now this is the hospital where I work. I come from Bangalore and I work in a hospital called Mallige Medical Center. I also run a small foundation. It's called as Mallige Smile Foundation, where we treat children born with cleft lip and palate free of cost, and we generate money locally. And I'm also the founder trustee for the world's biggest cleft lip and palate center in Hyderabad. It's known as the GSR Institute of Cleft Lip and Palate Management. We all would have seen at some point of time a cleft baby in our life. So you all must be wondering what really causes these kind of deformities. To understand these deformities, I'm going to take you back to a brief into embryology. Right? If you remember our embryology, the face is generally formed by three processes. The one is a single process which is known as the frontal-nasal process. Then we have a paired processes which is a maxillary process and a mandibular processes. These five processes unite in the center to create a nasal cavity and oral cavity. Any disturbances during this union can lead to formation of facial clefts. So like I said, the frontal nasal process forms the lateral and the medial nasal processes, and it also leads to the formation of the mid portion of your upper lip, which is known as the philtrum. And the paired processes, the maxillary swelling completes the upper lip, and the mandibular swelling completes the lower lip. I'm sorry about this delay in this change of slides. Now comes the intraoral developments. Intraorally, there are three portions of the palate, the two lateral portions and one the primary palate in the anterior region. If you remember, the two lateral portions of the palate initially starts growing downwards in a vertical direction, and then they pulled up. As the tongue starts growing up, the palatal shells pull up and meet in the center, and that completes the formation of the oral cavity, and it separates it from the nasal cavity. If there is a delay in descending of the tongue, or if there is a delay in elevation of the palatal shelves, this can lead to formation of your cleft palate. So this is a Tessier's classification. This is just to give you an insight what are all the variations of a cleft which can happen to us. So they are numbered from 1 to 13 based on the way they are situated. So it can go up to the craniofacial region. So involving only the maxilla, it can extend into the orbital rim and then go up to the frontal bone. So this is some of the cases what we have seen in our centers. We have a bilateral lateral facial clefts. The eyes have already developed the cataract situation over there due to constant exposure. So this is a pre and post afterwards on the other side. This is another unilateral facial cleft which is being managed post-operatively. This is again a developmental deformity where there is a missing lateral ala of the nose and the nostril on one side, and there is a transverse facial cleft onto the other side. And we also have conditions known as the hemifacial hypoplasia, where the mandible does not grow adequately on one side, leading to a swinging of the mandible to the one side. So I'm going to take you through some of these congenital deformity management, but in brief, I'm going to talk more about the cleft lip and palate management. To talk about cleft lip and palate, it actually requires a one-year program. It's a one-year program to teach you how to understand and operate a cleft lip and palate surgery. Now, the etiology for this, why do these things kind of developmental deformities occur? It could be due to a maternal infections, or it could be a metabolic disorders, or it could be teratogenic. Most of the things are not clearly understood, but there is a strong incidence of genetic predisposition in this, and there is also drug-related causes which causes cleft lip and palate. It could be a dilantin sodium or steroids or abuse of diazepams during the maternal time. There are a few syndromes very commonly associated with cleft lip and palate. The most common we come across is the Perry-Robin syndrome, and we have the other syndromes like Vanderwoos, Sticklers, and the Apert syndromes. Today, there is a possibility that we can diagnose this cleft lip and palate intrauterine by doing a 3D ultrasounds. The diagnosing of the cleft palate is almost impossible, but we can diagnose a cleft lip with a 3D scans. Now, to understand cleft lip and palate, we need to understand the normal anatomy. So there is a child here which is showing all the normal anatomical structures. So you have two small ridges on your center of your upper lip, which is known as the feltral columns. Then you have a dimple in the center, and then the skin and the vermilion border meet, leading to a small ridge over there. That is known as the white border or the Cupid's bow. What happens in cleft lip child is there is a break in continuity of this white roll, and there is an absence of filtral column on one side, on the cleft side. In the bilateral cleft, there is an absence of filtral ridges on both the sides, and there is no continuity of white roll which is joining into the midline. So if you remember the word normal, and then if you compare this with the cleft lip child, then you will understand what is missing here. Now, if you go back and remember our anatomy, orbicularis oris muscle is mainly a sphincter muscle. It goes in a circular form and it causes a sphincter. Whereas in a cleft lip patient, this orbicularis oris muscle is disoriented. On the non-cleft side, it gets attached to the anterior nasal septum, and on the cleft side, it goes into the columella of the nose. Various problems which we mainly come across in a cleft child is, the first and the most important thing is the psychological impact on the family members, and then there are feeding challenges, and for the child there is a psychological trauma as the child grows up, and there are possibility of ear infection, there's a possibility of speech issues, and these are all the problems which we need to handle it. So the management of cleft lip and palate surgery is a very unique field. The surgery has to be timed according to the developmental patterns, and these surgeries influence the development in the later age. So we have to plan when to do the soft tissue correction, when to do the hard tissue corrections. These are both aesthetic and functional corrections. So we have to plan this in a very strategized way to get an optimal benefit to the child. So when you come across a cleft lip and baby first, so it starts with the feeding instructions. So as you know that there is a communication between the oral cavity and the nasal cavity. So obviously the baby will be unable to suck. There is not a positive seal over there. So the feeding instructions has to be given to the mother. So they can also do a breastfeeding, but it has to be an active breastfeeding where the mother has to pump the milk into the baby's mouth, and baby should always be kept at 45 degrees whenever they are doing the feeding. And there are special bottles which are available which goes right into the oropharyngeal regions for suckling in order to avoid this negative suction created by the lack of spaces between the oral and nasal cavities. So these children undergo various surgeries at various levels. The first surgery is generally done at 3 months age, that is the correction of the cleft lip, and then when the child is about 18 months, we do a cleft palate surgery, and then when the child reaches about 9 to 10 years, that is when we decide to do an alveolar bone grafting. There is a separation between both alveolus. To create a continuation of the alveolus, we do a bone grafting at that age. So going back to the diagrams again, if you remember the anatomy again, like I said before, the orbicularis oris muscle is a sphincter muscle. So you can see that there is a complete orbicularis oris muscle surrounding and causing a sphincter around the oral cavity. Here the orbicularis oris muscle is attached to the anterior nasal septum onto the non-cleft side, and the orbicularis oris is attached to the columella of the nose, leading to the widening of the ala of the nose in this case. So there are various ways of classifying the cleft lip and palate. If there is a thin band holding the cleft lip together, it's known as the Simonot's band. So if that is present, then it can be classified as type 1B, and if it is missing, then it is type 1A without a Simonot's band. And then there will be a complete collapse of the nasal dome and without the collapse of the nasal dome. This is a classification which was given by the Hyderabad Cleft Society. It's the same thing again, without the difference of alveolar ridges and with the difference of alveolar ridges. This is quite more academic, so I'll go further into the management of these cleft lip patients. So generally, when you have to operate on a cleft child, we look at the role of 10. The hemoglobin should be 10. The baby should be about 10 pounds, which when you convert it into kgs is almost about 4 to 4.5 kgs. The child should be about 10 weeks old, and the WBC count should be about 10,000. The concepts in repairing a cleft lip is to obtain a nasal layer, to complete the anterior nasal layer and to separate the oral cavity and the nasal cavity, and also to complete the orbicularis oris, the concentricity in the oral cavity to reconstitute the sphincter effect of the orbicularis oris muscle. So the most commonly used or widely used the incision is the Millard's rotational incisions. We have, over a period of time, evolved our own incisions in both in Hyderabad Cleft Society and in my center, where we do a combination of rotation along with wavy incisions. Right? In a cleft scenario, there is no absence or there is no shortage of any tissue. It's just the tissue is disoriented. So the ideal principle of a cleft lip surgery is to reorient the distorted anatomy and create the normal into that. So in this, there are 3 layers of dissections done. The cutaneous dissection, the mucosal dissection, and the orbicularis oris muscle is identified. The orbicularis oris muscle is reoriented into the opposite side, and the suturing of the labial mucosa and the muscle is done. And then the skin suturing is done by advancement and rotation of the skin. Now this is how the results you obtain after you do a primary cleft lip surgeries. This is some of our cases pre and post-op over a period of time. This was in the pre-op on your left and post-op on your right. You can see the symmetry of the nasal openings on both the sides. Okay, this is the, you can appreciate the openings on both the sides. This is another case with the collapse of the dome. You can see that how the dome is collapsed in this case, but the collapse of the dome remains. So now we have started doing the primary septorrhinoplasty at the same time. I'll show you as we go further how the differences matter in the septorrhinoplasty. This is a unilateral partial cleft lip. For some reason, the statistics shows that there is more left-sided cleft in a girl child compared to the male child. And the cleft on the left side is more common compared to the cleft on the right side in a unilateral cleft. So these are really psychologically impacting surgeries. It influences the whole family and the child growth. See, the other extreme end of the unilateral cleft lip is the bilateral cleft lip. So when you have a bilateral cleft lip, you can realize that there is no orbicularis oris muscle in the prolabium. The prolabium is a projection from the frontonasal process, which joins the two lateral maxillary process to complete the upper lip. In a prolabium, there is a deficiency of the muscle tissue. There is only a skin and then the mucosa, and then you have the primary palate or the anterior palatal place. Again, this is classified as a premaxilla with confines to the arch, and those in conditions where the premaxilla is protruding outside the arch. So it is called as type 2A and type 2B. You can see that how the premaxilla is protruding outside the arch with the deficiency in the columella over there. So in this again, we do a same Millard's incision with the Pfeiffer's wavy incisions. The Millard incisions are placed onto the either side of the normal side, and the wavy incision is placed on the prolabium. The wavy incision and Millard's incision provides the adequate length, and it reduces the contraction post-operatively. So the incisions are marked. The orbicularis oris muscle is released from the attachment to the L of the nose on both the sides. The prolabium is separated into the cutaneous portion and the labial portions. The labial portion is retained to recreate the vestibular depth. Once the orbicularis oris muscle is dissected on both the sides, they are brought without any tension to the midline and sutured to complete the sphincter effect of the orbicularis oris muscle. You can see that the prolabium is separated out into 3 layers, the cutaneous layer and the mucosal layer. Right, the nasal sill is completed here in the anterior region of the nasal floor. And then the muscles are approximated after separating them from the ala of the nose bilaterally. The ala of the nose brought together symmetrically on both the sides. And the broad orbicularis oris muscle is covered with the mucosa and the skin on top. You can see that the orbicularis oris muscle is coming without any tension in the center, and it's sutured right in the midline without any efforts. So this is how it looks as the growth continues. So this is after about 2 years when the child is grown into the 2-year-old child. So you can appreciate how the molding of the premaxilla has happened along to the other side of the maxillary region. This is one of our cases. This is a bilateral cleft, a complete bilateral cleft on one side and a partial cleft on the other side. This is a partial bilateral cleft lip case. And this is another complete bilateral cleft lip with the prolabium positioned outside the arch. Once you create the muscle splinting pushes the anterior portion of the palate into the arch region. This is one of our pre and post-op cases. You can see how wonderfully we can correct it. This is also known as a morpho-functional correction of the cleft lip. So it corrects the function and it also improves the morphology of the upper lip. So these are elder children. You can see that there are teeth visible in the upper anterior region. They're almost about 8 months old. So sometimes we do a septoplasty at the same time. Now, why do we have to do a septoplasty? You can see that on the normal side, because the orbicularis oris muscle is attached to the anterior nasal spine, it tends to pull the nasal septum onto the non-cleft side, leading to the deviation of the anterior nasal septum. So when we place our skin incisions for correction of the upper lip, at the same time we can detach the nasal septum and bring it to the center. So you can see that, you can appreciate how the nasal septum is visible here from the skin incision while correcting the upper lip. The nasal septum is detached from the anterior nasal sign and positioned in the center, and then it is gently wrapped around the nasalis muscles and sutured over there into that place. So leading to, as the growth continues to happen, you can avoid this kind of deflection. Earlier you could see that the nasal septum was deflected onto the normal side. So once you correct it, the growth comes into the center. So this is known as a septochelioplasty, which is done along with the primary lip corrections. Again, another case of an unilateral cleft lip with a massive deflection of the nasal septum, which is corrected at the same time while we corrected the upper lip. Now, once the lip is more of an aesthetic correction, whereas the cleft palate correction is more to do with the functional correction. The correction of cleft palate lead to in assistance of both the speech and the swallowing. So this has to be timed at 18 months when the palatal shelves are grown and there is adequate muscle available in the soft palate region to create a closure in this. I'm going to quickly rush through some of the techniques what we do in this cleft lip and palate surgeries. This is a normal cleft palate. It shows all the 5 muscles what we have. We have tensor veli palatini, levator veli palatini, palatopharyngeus, and musculus uvus. The first 3 are the paired muscles, and the musculus uvus is a single muscle in the soft palate. In a cleft palate, what happens is all these muscles are again reoriented and they get inserted to the posterior portion of the hard palate. Instead of negotiating itself into the midline, they get attached to the posterior portion of the hard palate. So the idea here is to separate out these things and then suture them and get them into the midline. So here the 3-layer suturing is generally done. You have a nasal layer, then you have muscular layer, and then you have the oral mucosal layer, which completes the normal formation of this. They can be classified into isolated cleft palate. You can consider it into submucosal clefts, or a cleft of both hard and soft palate, or the cleft palate of only the soft palate in this. You can do these palatoplasties either as a single stage or as a 2-stage. I'm going to take you through both the things, and the literature has shown that there is no huge difference between a single stage or a two-stage procedures. Only thing is surgically it makes it easier when you do a two-stage in a wide cleft. So when you do a single stage, we raise a flap on both the sides. Both the slides on the palatal sides, they are supplied by the greater palatine vessels. It's important to maintain these greater palatine vessels and raise the mucoperiosteal flap onto the palatal shelves, and then reflect the nasal mucosa along to the palatal shelves on either side and bring them close and suture it. Create a closure of the nasal floor first, and then advance the two pedicles in the oral cavity and close them in the center. So thereby you are creating a barrier between the nasal cavity and the oral cavity. There is also an option of creating a Z-plasty, which is not, I use to do a Z-plasty only to lengthen the soft palate after doing a primary correction, or if there is a lot of severe contraction, then I do a Z-plasty to lengthen them. There are clinical representation of both these cases. You can see that this is a complete cleft involving the hard and soft palate, and you can see that the bifid uvula on both the sides. So the flaps are raised on both the sides, and this is allowed to go for heal for secondary intention of healing or a granulation on both the sides. There's again another case with two flaps raised on either sides. The nasal layer is sutured first, and then the palatal layer is sutured in the hard palate region, and in the soft palate region there is a muscular layer which is sutured. After you close the nasal layer, then the muscular layer is closed in the soft palate, and then the oral, the pedicle flaps are repositioned. It's more like a sliding flaps, which are positioned in the centers and gently sutured without much tension in this. These are all the cases of pre and post-op. Another case where halfway through the nasal cavity is closed and then the oral suturing is happening here. And this is how it looks after healing. Right? So these are all the one-stage palatoplasties. So when you look at it, even after 8 years, it holds good, and then the chances of fistula developing is quite rare. But the fistula development can happen more commonly in the junction of hard and soft palate region. There is also a possibility of doing it in a two-stage procedures. When you do a two-stage procedure, it pulls the maxillary shelves together and reduces the distance between the cleft side. So we can do this two-stage procedure where you do a soft palate closure at 9 months, and then you take the child back again into the OT at around 16 to 18 months to do the complete palate repair. So this is a comparison. If there is a wide cleft, if you're not comfortable doing it initially, you can do it as a two-stage. This is an example of how you do a two-stage. You do a lateral incisions on both the sides on the palatal side to advance the mucosa into the center and then leave the anterior palate open. So when you do this, it acts like a pulling forces and brings the palatal shelves together. You can see how the distance between the palatal shelf is reduced when we did only the soft tissue closure. Then later on we went on and closed this. So there is there's a clear indication for doing both of this, but the literature says that the complication rates are same in both the conditions. So that was a soft palate closure when the child was about 10 months old. Then we went back, took the patient inside and completed at 18 months both the hard and soft palate closures. So again, showing you the examples of two-stage corrections, how it narrows the cleft between both the sides. So now the cleft lip is corrected and the cleft palate has been corrected at the age of 18 months. And next comes the surgery to do alveolar bone grafting. Alveolar bone grafting is, there is a discontinuity between the normal side and to the cleft side. The alveolus is generally a U-shaped sausage in the oral cavity, and there is a break which leads to an absence of canine or a lateral incisor. It also causes support to the lateral ala of the nose. So if the alveolar reconstruction is not being done properly, then it leads to collapsing of your ala on the other side. So this is how a cleft alveolus looks like. It's a pyramid-shaped deformity running into the pyriform rim and up to the hard palate. So generally the flaps are raised on both the sides. So you create a flap to palatal side, onto the labial side, and the nasal floor. And you do a watertight closure onto the nasal floor first, and then you do a closure onto the palatal side, and then you keep the gaps open between the two bony edges. So this is a nasal floor is created here, and then the palatal flap has been raised. Now, ideally, the bone should be a cortico-cancellous combination in order to encourage rebone formation in the cleft side. So we take the bone from the iliac crest. So either you can harvest a chunk, or you can use a trocar, which is less traumatic than using a chisel to harvest a chunk over there. I generally use a trocar to harvest a bone, which comes with both the uniform portions of cortical and cancellous bone. These are the instruments which are needed, very simple instruments and a simple technique with the least complication for the child from the donor side. So once the bone graft is harvested, the bone graft is packed between the two bony edges. So this gives stability to the maxillary arch. It also allows enough bone for the lateral incisor and the canine to erupt through these things, or you can even go in for an implant later on to replace the missing tooth in that. So this is how it looks like, the graphic representation. This is a radiographic showing how the cleft was here, and then after the graft, you can see that the bone is nicely filled up into this place. You can also see how an erupting canine has grown into its original place because the availability of the bone. Otherwise, the child would have not had this canine in this place. But this is a clinical representation of a cleft alveolus. Right? This is from the iliac bone graft. This is how the graft material looks like. The flaps are raised, the graft is placed, and then it's sutured. And this is a pre-op radiograph and post-op radiograph after the graft has been placed. You can see that there is a continuation of the maxillary arch on both the sides with a new bone formation in the cleft region. Next comes the skeletal deformities which are commonly seen in a cleft child. Due to the surgeries, there is a severe contraction of the maxilla. The maxilla goes into the hypoplastic state where there is a retarded growth in relation to the midface. The mandible continues to grow normally, but there will be a growth which affects to the maxilla. The maxillary growth gets affected. You can see that there is a severe hypoplasia, like Dr. David suggested. It's a dish face deformities in these cases. The mandible is much more forward. So these are some of the cases when we do a maxillary osteotomies and mandibular setback. Most of the cleft patients will require a bijaw surgery. This is still too early post-op. So there's still a little bit more swelling left on both the sides of the cheek. You can see that the patient has undergone maxillary advancement. She has undergone a maxillary advancement and a mandibular setback with the reduction genioplasty to obtain this profile. This is a radiographic picture, pre and post. You can see the difference between where the maxilla was positioned, and you can see how badly the midface is hypoplastic in this condition and how the mandible is grown forward. So in this, the mandible and the maxilla was advanced and the mandible was taken back. This is a pre-op and post-op of the same patient. This is another case where again a cleft child with a maxillary advancement and a mandibular setback. Most of these patients will require a bijaw surgery. She also underwent a rhinoplasty at the same time. You can see that the nasal hump reduction, and we gave a support to the columella at the same time. This was the case which I showed you before, which is a hemifacial hypoplasia patient. The patient had deficiency of growth on one side. So here we did a distraction in this. You can see a distractor pointing out in this. The mandible was cut in the center, distractor was placed, and gradually the callus was distracted and allowed the mandible to grow into the normal side. So once the growth was achieved, then we went back inside and removed the distractor. After that, the mandible continued to grow normal. The last part of the cleft surgery is the cleft rhinoplasty. So this is the final aspect of the child management born with cleft lip and palate. So some of these cases, we go in, there will be a requirement of cartilage, there will be a deficiency of the cartilage. The cartilage can be used from the same septum which is harvested, or we could take a cartilage from the auricle, or it could be a costochondral graft. Depending on the volume or the amount of cartilage you need, you can harvest this from any of these three cases. It's a standard rhinoplasty done. You can see that the costochondral graft has been sculpted and placed in the center to provide the stent over there. That was a stud graft. This is almost like a binder's syndrome. There the patient did not have any nose at all. His nose was pressing down into the upper labium. This was after the operation. You can see how the nose is standing up in this case. You can see that. We did a complete redo of the upper lip and the nose for this lady. This was after the rhinoplasty and after the upper lip which was done. This is a profile. This is another cleft nose. With the osteotomy, the cleft rhinoplasty was done for these patients. So this was the case of the lateral facial cleft or the transverse facial cleft. The mouth becomes the modulus which is there at the end gets shifted much to a posterior region, and this is after the operation. His cleft was running till here, and we have got back his oral cavity into the same size before. And this was as shown earlier, the bilateral facial cleft. Another case of bilateral facial cleft. Another case of bilateral facial cleft which was operated. So in this, there was a wavy incision was formed. The Pfeiffer's wavy incision was applied in this to bring down all the anatomical structures way down. So with this, I end my lecture. So thank you very much for patiently listening.
Sir, great results, I should say. So one thing I want to ask is bilateral complete cleft lip with category 2A, one with protruding premaxilla. How do you manage tension-free closure? Do you still do NAM or?
Sorry, say that again?
The bilateral complete clefts with protruding premaxilla. If after the confines,
if the baby is too young, then we try to do unilateral first. If you're able to complete it on both the sides without any tension, if I can get the orbicularis oris muscle to meet in the midline across, then we go ahead and do it in the first stage itself. Otherwise, we do it as a two-stage procedures. Sometimes you can even use the bumpers, the lip bumpers, to push the labium inside and wait for it to develop, and then later on go in and do the lip corrections.
Can bone osteotomy be a good option?
Omoidal osteotomy, I do it if the child is a little older, not at such young age. If the child is a little bit more older, then we think of doing an omoidal osteotomy and fixing it up either with a K-wire or with a good suturing at that time. Not by a very 3 months or 4 months old baby.
Thank you, sir.
Thank you.
Thank you, sir. That was a very informative session. And with very limited period of time, you have touched all the points of the cleft lip and cleft palate, including the facial cleft and lateral clefts. It's like a really good achievement, sir. Thanks for such a wonderful session, sir.
Thank you.
Thank you, sir.
Thank you.
Now I would request the chairpersons to felicitate, sir. Thank you, sir. And now I request Dr. Syed Mushtaq Hashmi, sir, Professor and HOD, Department of ENT, KBN, to felicitate our chairpersons for the day. Thank you, sir. Now to continue with the last segment for the day, we have a panel discussion with our moderators, Dr. Ali Patel, sir, Professor in HOD Department of Dental Department, KBN, and Dr. Zaman Muslim Amin, Professor and Head of the Department of Forensic Medicine, Faculty of Medical Sciences, KBNU, as the moderators. And I would request Dr. David Toro, sir, from the Tolerance Clinic, Center for Craniomaxillofacial Plastic and Reconstructive Surgery, Bangalore, to please come up on the stage. Dr. Srinath N, sir, the Honorary President of Karnataka State Association of Oral and Maxillofacial Surgeons. Dr. Girish Gowda, sir, Associate Professor from the Sanjay Gandhi Trauma Center. Dr. Mohammad Ibrahim, sir, Professor and Head of the Department of Orthopedics from Gulbarga Institute of Medical Sciences. Dr. Abdul Basir, sir, Professor from the Department of Surgery, Faculty of Medical Sciences, KBN University. Dr. Deepika Rani Patil, Madam, Assistant Professor from the Department of ENT, Faculty of Medical Sciences, KBN University. To please come up on the stage. I would also like to request Dr. Manshetty, sir, from the Department of Surgery, Neurosurgeon, Faculty of Medical Sciences, KBN University, to please come up on the stage. Check.
Good afternoon, ladies and gentlemen. Thank you for your time and thank you for spending your precious time with us today and listening to lectures from eminent guest speakers from all over the state. And we've covered a variety of topics ranging from maxillofacial trauma to correction of developmental deformities like cleft lip and palate. And we've covered TMJ, which forms very important for the maxillofacial surgeons and the dentists. And we have also covered orthognathic surgeries, which is important from an aesthetic point of view. So the last part of the session today is a panel discussion which we proposed, considering the fact that Dr. Ali Patel is also an integral part of the emergency medicine of KBN General Hospital, teaching in General Hospital here. He handles the ICU of the KBN Hospital, and the management, the university, has immense trust in him, and along with the team of the other surgeons, he is, as such, as in charge of the emergency department. And the most important thing is it's a teamwork. So now the point comes is a teamwork of medical and dental faculty. And the reason we are here today, which is very good, is being a medical college and a medical teaching in general hospital, we got an opportunity to sit and have a continuing professional development program on a dental subject, that is maxillofacial surgery. And now we are sitting down on a discussion to discuss is maxillofacial surgery, or I would say a specialist in dental field, do you think that person should be a part of an emergency medical care in any medical hospital? So today here we're in KBN, it's a teaching general hospital, but do you think as audience and all my panel members who are all experts in the field, do you think a dental person who's a specialist should be a part of an emergency medical team? And there are reasons for it. So I'll begin with my first question, which is linked to trauma. How important do you think is the role of a maxillofacial surgeon in cases of trauma of the maxillofacial complex? Now this question to the audience as such would have come up, if it had come up in the morning before the CPD, it would have been a little vague, but we covered trauma extensively. We covered all the other corrective procedures, and I will just briefly highlight and tell you what I have in mind, myself and Dr. Patel. If there is trauma only to the jaw bones, it can be handled, that's only the maxilla and the mandible, it can be handled standalone by a maxillofacial surgeon, sometimes on the chair side, sometimes under general anesthesia, even in a private nursing home. But when this trauma involves jaw bones and surrounding structures, say the orbit, the temporal involvement, the nasal bones, nerve involvement, soft tissue involvement, then maxillofacial trauma becomes more complex. So it doesn't become only jaw bone trauma, it becomes maxillofacial complex as such. At that time, it is the role of a surgeon as a teamwork. So do you think as maxillofacial surgeons that without you, this can be managed?
Ma'am, I think I have 2 points to disagree with you. Right? The first thing is, I think you are using word, should we allow a dental graduate to be in the casualty or in the hospital setup? Right. So I think you should refer a particular specialist. Like how you refer them, you call him orthopedic surgeon. You don't call him a medical doctor. Right? The same way you call him a neurosurgeon, you don't call him a medical doctor. So same way you have to call us as a maxillofacial surgeon, not as a dentist. The reason why I said this is we go through more extensive training in our field, maxillofacial surgery. We spend time with neurosurgeons. We spend time in trauma centers. We spend time in oncology centers. We spend time in cleft lip and palate centers to understand and inculcate the knowledges. And our syllabus covers the complete management of the trauma. The primary management of trauma, what we call it as the ABCDE, is taught to us. We are trained to perform tracheostomies. We are trained to intubate the patients. We are trained to assess the Glasgow Coma Scale. Of course, a neurosurgeon cannot handle a facial-maxillary trauma. A facial-maxillary surgeon cannot handle a neurotrauma. So it's a teamwork. At the end of the day, it's absolutely a teamwork. So without a team, the patient will not survive, and we will not be able to do justice to that. So there are certain emergency situations where a maxillofacial surgeon is needed, but not in all trauma cases. The primary stabilization of the patient is an intensivist and a neurosurgeon. Once the patient is more stable, then the maxillofacial surgery happens only after the patient is stable. So that is usually after about 3 or 4 days later. Very rarely we come across with an emergency which requires immediate intervention in a maxillofacial trauma, unless there is an airway obstruction or if there is a bleeding.
So if I can interrupt you, there are two possibilities here. One is that all cases of maxillofacial trauma require the attention of a maxillofacial surgeon, or are there a few cases, a remote possibility you think which can be handled standalone by other surgeons?
It depends on the competency of the surgeon.
Mm-hmm.
If you have a competent surgeon other than a maxillofacial surgeon who can handle it as good as a maxillofacial surgery can be, so he can do it.
Can I say something about that? I think what Dr. Srinath said was absolutely right. Then you see, every specialty has its. So, you just can't mix things up here. Just like I said, a neurosurgeon cannot manage a maxillofacial trauma and vice versa. Now, for example, if you have, this is what we spoke about in terms of jaws, the occlusion, the TM joint, and blah, blah, blah. This itself is a science by itself. So, understanding the stomatognathing system, understanding occlusion, no matter what I said, competence in terms of fixing things. I have seen enough surgeons who have just put a plate, and then if there is an occlusal disparity, they say, no, you go to the dentist. That's not how it is. You fix a plate in a jaw based, the key is occlusion. You don't just fix a plate and say you fix the occlusion later. The key is occlusion. So the key to reduction of any maxillofacial, particularly anything below the cranial base that involves the maxilla and the mandible, the key is occlusion. So you fix plates based on the occlusion. So if there is somebody who is managing something without looking at occlusion, then the question about competence comes in again. So there is no question of competence here. I think somebody who is trained in the specialty is the right person to deal with it. That's it. So I don't think there is a debate whether this one or that one should be there. I mean, it's a teamwork. It's a specialized work, particularly when you're dealing with horrendous trauma. If you're talking about an isolated fracture of the mandible, maxilla, or a zygoma, it's not a big deal. And again, closure of the soft tissues becomes an issue when people talk about, who will close the soft tissues? I mean, if somebody is trained to close soft tissues, you can do a good job because I was not born a plastic surgeon or maxillary. I've honed my skills over a period of time. So if you can hone your skills with something, if you can hone your skills as an orthopedic surgeon, you can hone your skills as any surgeon. And if it is something to do with surgery, I mean, particularly facial sutures, if you're dealing with facial cosmetic surgery, be it plastic surgeon, maxillofacial surgeon, you better hone your skills before you put a stitch there. So if you're not competent enough, you better not suture it. That's it. Simple as that. But then, the issue of closing tissues should be taken care of because, in certain specialties, for example, in gross injuries, people don't bother about closing it in terms of doing a good plastic closure. That's important. Even in cancer surgery, for that matter, I take extreme trouble to put the last stitch even in cancer surgery because it's important for the patient. So that's how it is. So I think there we are.
Good evening to all. Thanks to the organizers to involve us in the maxillofacial department, as we are also a trauma surgeon, as I am an orthopedic surgeon. The basic principle nowadays is treat the patient what you knows. Okay? Because the science and technology has extended into such a way that every part or every organ or everything of the body has its extensive level of research. So if a person is trained in some part of the body with extensively involving in that part, he can give you a best result in that part. I am a surgeon, I may know all the parts of the body, but the experience over operating in that part of the body depends how you are involved in that part. So the concept of trauma or trauma care now depends mainly to give as normal as possible functional relief to the patient. So if a surgeon who is an orthopedician but has been trained for a long time in the maxillofacial department and is a better surgeon than a newly come any surgeon, don't take it in the wrong way, but my major point is that the thing is you are specialized in some special subject, then you can give you a best care in that part. So now everything has come. In our department, I will tell you, there are plastic surgeons. They are involved in the joint replacements. There are pelvic acetabular surgeons. They are involved in the pelvic surgeries. So commonly now the trend goes towards what you are specialized, give that complete treatment to that specialized part of the body. So nowadays there is a trend that, and it should be a positive trend, that involving the specialist in the treatment of the patient who is having a best knowledge in that part will give you a best result to the patient. Earlier there was scarcity of the surgeons, specialists, and the advancement was not so much, so everything was done by a trauma surgeon. So that's why nowadays, in my opinion, and what I have one of the experience to share the trauma care center as a in charge in Gulbarga Institute of Medical Sciences. So that experience is that now whatever that comes to the casualty, there is now NMC also indicated there should be an emergency department. It is now compulsory. Emergency department have a 5 subjects: general surgeon, neurosurgeon, maxillofacial surgeon, anesthesiologist, and a physician, and with an orthopedician. So these are the specialists guided by the NMC, National Medical Council. So in my opinion, everyone is a key role, has a key role in treating an accident care or a trauma care patient. Thank you.
Good evening, everybody. A wonderful panelist and a good discussion is going on. Two things I had caught my attention. One is what Madam was discussing, aesthetics involved, and the other thing is the reduction. As Sir said, these are the two key things. See, otherwise, it's just any other bone, it can be fixed by an orthopedician also. And you not be a neurosurgeon for that. So, yes, end of the day, it is, OMF is evolving as a subject, standalone subject, yes. As was the question of treating a jaw bone fracture as an independent surgeon under his care, yes, definitely it can be done. As pointed out by Sir, it's not a rocket science understanding the head injury and assessing the Glasgow-Coma scale. Any competent OMF surgeon with good training can assess the patient and take under his care. So yes, the two things which caught my attention was reduction. Unfortunately, with whatever reasons, it should not be missed, and that is the most key thing, that's the basis of an OMF surgeon's reduction, occlusions and fixation. Otherwise, as Dr. Ibrahim has said, it's not a big thing. Earlier, because of scarcity, and the neurosurgeons to do so many things, even general surgeons would have it done. So it's all from the parent of general surgery, neurosurgery came out, general oncosurgery and all. So yes, the future is bright, and that should be the motive of this discussion also. Thank you.
Thank you, organizing committee, for including me for this panel discussion. First thing is involvement of maxillofacial surgeon. Yes, there is definitely a role of a maxillofacial surgeon in a trauma team. As a part, a general surgeon is there, neurosurgeon is there. They are all involved. It's about, as Sir has said about the training of the ABCD. ABCD is for all the surgeons, all the medical fraternity, irrespective of the department they are in. It's about leading the role of a trauma team and stabilizing the patient. Next come the management, how to proceed with what kind of treatment the patient involves and which department he has to be treated first. As a maxillofacial surgeon, their role in a trauma team first is the airway. That is, unless you know that airway has been stabilized properly, the next step cannot be proceeded. Patients who are having three fractures or severe facial edema, or there is complete shattering of the facial bone, whole thing is back of bones with only skin intact. There the role of intubation and initial stabilization, management of hemostasis. These are to be done immediately to stabilize those patients, and intubation. Those patients, like as Sir said, tracheostomy. Tracheostomy is a part of team for even for an intern to know that tracheostomy to be learned. needle tracheostomy or direct tracheostomy to be immediately done, and the next ongoing procedure will start. Next is in case of contaminated wound. If the maxillofacial surgeon is there at the time of injury, he knows what kind of injury it is and what amount of contamination is there, so that he can take according the steps and when he has to proceed for the surgery. His role is also there when there is an edema on the face, like the type of injury the patient has attained. He can predict that the possibility of respiratory compromise in the ongoing stay of the patient. As ma'am has asked, like, what is the role? Yes, ma'am. This is the role of a maxillofacial surgeons in acute care. Once the patient has been stabilized, the next step for the management, stabilization of the bone, and sir has already mentioned about the occlusion of the teeth. It's not as our maxillofacial surgeon has always said, it's about the approximation of the jaw. It's not about the symmetry of the face. If the symmetry is here and there, is okay, but if you cannot bite the food, then it's of no use. Definitely, the maxillofacial surgeon, as a part of post-emergency care, also is there. Thank you, sir.
Thank you. Yes, sir.
So as a part of, I work in one of the renowned government institution in Bangalore. So as a maxillofacial surgeon, even I am posted in casualty, for casualty duty. See, according to NMC, as I mentioned, actually it is a very good thing that NMC has been included our maxillofacial team as well as one of the emergency things. Is a very encouraging words, and it's actually encouraging for our younger generations. So what I wanted to convey this to my maxillofacial surgeon is, we have given a proposal saying that NMC is already included in us as an emergency team. So we have, the government, central government is coming up with every 10 kilometers there will be one national hospital in a center scheme. So we have applied from the central government. We have requested the central government to include even every center should be appointed one of the maxillofacial surgeons. See, this what happens is the opportunity for compared to medical fraternity, when you compare to maxillofacial surgeons, the opportunity is comparatively less. Frankly speaking, see, if you make 100 cases of trauma, orthopedics, usually most of 80 cases will be orthopedicians. But exclusive maxillofacial or maxillofacial injuries will be lesser than 10 or 20%. Frankly speaking, after IMED, definitely it has been reduced to a single digit. So the opportunities is quite less for us. I mean, cases wise I'm talking about. So central government is thinking of include the guidance of NMC and part of every hospital, central government hospital, national hospital, they are planning to include the maxillofacial surgeon also. So nearly more than 9,000 change of surgeons may be appointed in the coming days. So I don't know whether it will work, it will implement it, but it's on the way, the process. So it's good encouraging words for our maxillofacial surgeons. So after immediately after dentistry, I think you should seriously think about doing a maxillofacial surgery. So I just wanted to convey this to our younger generations. That's it.
Thank you, Girish sir. I have a question to Srinath sir, as he's honorary president of the Karnataka State Association of Maxillofacial Surgeons. So, has the association taken any steps to recommend the NMC to appoint maxillofacial surgeons in the emergency medicine department of a medical college?
The National Association is in touch with the NMC, and like Girish and Sir said, there's a strong move, and the government has been sensitized about the role of maxillofacial surgeon in every trauma center across the country, and there is a favorable response from the government. And coming days, like Dr. Girish said, there's hopefully it will be implemented, and most of our fellow maxillofacial surgeons will find government opportunities to serve the trauma. So we can serve our country better. So as a maxillofacial surgeon in the trauma team, hopefully it will be good for all of us.
Thank you, Srinath sir.
I have a question for the President and Dr. Girish, since you handle trauma cases. Do you think it is important now for a maxillofacial surgeon to have knowledge of documenting trauma for medico-legal cases?
Right. Coincidentally, I just received a message on my hospital group. One of the doctor had posted, how long do you have to store the documented data? If it's an MLC, you are supposed to store it till the case gets over.
Exactly.
And if there is a death, it has to be kept for a long number of, I don't know, there's unlimited time if the patient is dead. And if the patient is operated in a trauma case, I think it's some 6 years or something, the documentation has to be maintained in the hospital.
So are the maxillofacial surgeons documenting trauma? That is, from the time the patient comes in, are they identifying the injury as what type of injury it is and writing a wound certificate?
I'm sorry, I understood your question. It's the second time when you asked me. You're right. See, I work in a trauma center. I work in a private trauma center across Bangalore city, and each hospital has a policy to document the traumas. So we have a documentation record book, and we also have the trauma is documented in all the hospital centers as per their hospital policies.
But maxillofacial surgeons should have an knowledge, because the surgeon is going to see if it's a hospital like KBN, if it's a private place, if it's a hospital where you're working, he's working. There's a casualty medical officer who usually records the MLC and documents the whole case. But if the case of any trauma comes up to any maxillofacial surgeon, even in a private practice, and this, because as a private practitioner, as a healthcare provider, our usual first aim is to go for treatment for the patient and benefit of the patient. We often tend to miss out on the medico-legal aspect of it, which unfortunately ends up the doctor later in trouble. Like all the practitioners end up getting in trouble if they've not documented it. So do you think the association should recommend that all the maxillofacial surgeons should have a general awareness of how to document the trauma?
Ma'am, I think to go back one step behind, every doctor, when an emergency comes to him, be it a dentist or a maxillofacial surgeon, should record the patient's version and the clinical examination and what steps he has taken. It is a rule. It doesn't have to come from our association. I think it is part of the training. You have to document it and you have to put it across. You have to give it, like suppose you give a reference to the oral and maxillofacial surgeon, you're supposed to record that as well, that the patient has been seen by me and assessed and found the findings, additional investigations asked for and referred to whom. So this documentation is must. It is, they have to do it, otherwise they'll be in trouble. It's a law. It's not even, I would not say it's academics. I think it's a law that you have to document.
It is the law.
It's a law. It's a law that you have to document it.
Mm-hmm.
Even if you're a simple physician or even if you're a simple dentist, if anything comes to you, you have to record it.
Yeah. No, I think there's a slight misunderstanding. Because in a medical hospital, every medical practitioner undergoes training in forensic medicine, which deals with the separate section on medical law and ethics. Unfortunately, we don't have that chapter in dentistry when you're doing BDS. Yeah. And as we move on with our specialty and we practice surgeries, like you're a maxillofacial surgeon, and we go more into practicing surgery and the operating part of it. So we do not know what law, under which law of the IPC a doctor can get booked for not documenting as an MLC. MLC is documented. But how, for example, I was listening to the lecture of Dr. Girish, how he describes abrasions, lacerations, his whole classification of wounds as a surgeon was different from the classification of wounds which I teach in forensic medicine from a medico-legal point of view. So I was thinking, isn't it important, especially in the dental field, because maxillofacial surgeons are the ones who are dealing with trauma, at least they should have, like even in the PG level, one chapter or one orientation workshop in which they identify the wounds from a medico-legal point of view and put it down on paper.
Yeah, I think being a Senate member, I was part of the Rajiv Gandhi Health University. So during my time when I was a Senate member, we went through the curriculum. It is mentioned in a maxillofacial surgical curriculum that there has to be one lecture on it, but we have not been following it up. I think what you said is true. There is a lacunae. It also comes to us, I think many times I and Girish have discussed, when the patients come for disability certificate, what is the percentage of disability you're going to give? That is, again, I think Girish wants to answer about that. The percentage of disability when you lose a tooth.
let me start with one example. I am working from past, in this maxillofacial profession, I am from past 15 years, I am there in this profession. Actually, I handled one gunshot injury, some kind of 8 or 10 years back. So by that time, I was a 5 or 6 years old postgraduate, and I was like, yeah, I was trained, and I was just new to the government institution. So I retrieved the bullet. I documented each and everything because I knew how things works. So I documented where the bullet went, how much the entry wound, exit wound, and how it, everything I documented. At the end of the day, I got a notice saying that you missed out, when you retrieve the bullet, you missed taking the part of entry tissue. Where the bullet enters, we have to take the part of the entry tissue and send it for the lab for the further investigation. See, this is a very technical things, which I didn't know. This is not part of the academic. I don't think so it should be a part of the medical field also. It's a everyday learning process. See, what I said is I understood. I think definitely, I think NMC or even our dental council should seriously think about including more of technical way of handling the medical legal cases. So, yes, we have actually technically, academically, we have forensic odontology. It has been included. If suppose if there is any untoward murder or anything, there is a special branch in our dentistry is known as oral pathologists. So they are not part of like forensic odontology. So they can go and identify the age of the patient who was dead or any bite wound, kind of things. But it is not totally, it has been implemented, frankly speaking. Yes, we are little lacking in that. Maybe the respective bodies, something like IDA, Indian, our association, service president is there. I think they should go further, take it in one more step ahead to approach since Sarah is also involved more into a Senate and Rajiv Gandhi University. I think the next process definitely should be considered to include in this. Include not only for the dental faculty, I think the technical things should be implemented for medical faculty is there.
Medical faculty in NMC,
I would like to answer this question also. There is a forensic department which is definitely it is there for the medical field also. But again, as I mentioned, because I took a help from one of a plastic surgeon when I retrieved the bullet, what to write. So he told me everything and I wrote it. Then when I got notice, I went and I approached him. What is this? You misguided me. He told, see, whatever is there in my academics, whatever my knowledge is, I told you. This rest is up to you. I didn't know that we have to take a tissue biopsy. See, this is over a period of time. Then we consulted one more senior surgeon who does only gunshot injuries from the Victoria Hospital. Then they told, hey, it's very mandatory. Then I realized, see, it's a learning process. It's never ends. But yes, technically we should definitely we should implement that. I think people like Srinivas, who is more, they should think about it.
I think if you have anything in your mind, we will have a discussion after this.
Yes, sir.
Please do draft us out, and we will try to. I think it's a very good suggestion.
Correct.
Thank you for bringing it up,
Thank
and we will discuss about this.
The reason I brought that up was because, like Dr. Girish said, I'm an oral pathologist, and I also did my specialization in forensics from UK. And I did both forensic medicine as well as forensic odontology and forensic science. So I studied all the three subjects together. So in gunshot wounds, when you send the sample, it's for the gunpowder, the kind of soot that you get. And I would want all the maxillofacial surgeons sitting out there, the PGs and the practicing surgeons, to know that there are two types of injuries when it comes to medical legal cases. It's called simple and grievous injuries. Now, loss of a tooth in any assault is considered as grievous injuries. The moment there is a grievous injury, it comes under, it's a different section of the IPC. So all the surgeons, maxillofacial surgeons, even dental practitioners, when there's an assault and tooth avulsion, should record it as grievous injury, because if at all it turns out to be one MLC, the section will be completely different. So my suggestion, my request to you would be that maxillofacial surgeons are the ones who are going to deal more and more with trauma, and we train the PGs starting at the PG level, at least for the future. We start the postgraduates now and teaching them how to document trauma and have a little bit of knowledge on the medical law that exists in India, at least now.
Thank you.
Would you like to enlighten us in our upcoming conference?
Yeah, sure.
It's in your parent place, Alma Matters, Dharwad.
Oh,
So please accept our invitation. It'll be in September 15th and 16th, and we will send you the time and.
Sure. That will be really good because that's a role which I would like to play with the dental surgeons, the maxillofacial surgeons.
Thank you for accepting our invitation.
Thank you so much.
And we are looking forward to learn from you.
Thank you so much.
To add over the medico-legal issues in the private practices, we have our Karnataka Medical Council. There they have given the detail how to take a prescription, how to examine the patient and how to give the certificates to the patient. Most probably dental council also have the same issues. So medico-legal things has been explained in detail in that website and in our council, what we medical practitioners follow that one. So most probably dental council has the same pattern of prescribing and everything. So please, nowadays it's a time of social media and everyone wants to catch hold the doctors where we are the soft target. So please follow the guidelines whatever given from the council. If you follow that guidelines, so 99% of the time you will not face any medical issue in your day-to-day practice. This is my one of the suggestion as a practitioner. Thank you.
I think there is a gazette notification from the central government about the grievous injury, simple injury. So we usually refer to that book before we go to the court. Because I work in few private hospitals and many times, sometimes I'm pulled by the law for giving MLC witnesses. So, how do you justify that it is an attack by a knife? Why not it be by a stick? And you have to explain all those things when you go to the court. So there is a gazette notification which...
These things has been followed in that guideline. Whatever the Gazette has given, accordingly they have made a criteria how to do step. I don't know about the dates, but it has been displayed very clearly on the website of Karnataka Medical Council. How to write a prescription, how to write a examination point, how to write your even diagnosis and how you want to proceed. The same guidelines has been followed everywhere in our medical practice. I don't know about dental council, but it was because nowadays even giving a fake certificate as a part of treatment that he was under treated for 1 week and given rest, that if you are not registering in your OPD register and if you are not having the consultation fees, it will be taken as a fraudulent document. So these things are there. So I'm not telling in the wrong way, but you should follow the guidelines. If you are under the guidelines, you will not miss the things. That's my point. That's all.
Thank you, Dr. Ibrahim. I would like Srinath sir to give us conclusion, like what is the future for maxillofacial surgeons to end this panel discussion?
The future is bright. Except that there is I think the new version is the threat to the specialty is not from within the specialty, it's from the outside the specialty. So we are facing a threat from engineers, especially the AI, the artificial intelligence and the robotics is the future threat for us. But we have to incorporate them, either we go with them or they will replace us. So you have to be at the cutting edge of technology. We have to keep on moving forward. I think from the days I started maxillofacial training, I started my training in 1992 when I entered into the maxillofacial surgery. At that time, the cleft was never heard of. We were only considered as tooth and bone surgeons. Right? From the tooth and bone, we have gone up to the microvascular free flap, the craniofacial surgery, and the aesthetic correction, the Botox, the fillers, and we have gone into lasers, we have gone into hair transplant. The specialty has widened its scope day by day. So there is every young maxillofacial surgeon sitting over there can find his groove. He can find his groove and survive and be successful in this. But whatever he wants to do it, he has to do it passionately and with humanity in mind. That's what I would like to say.
Thank you, Srinath sir. So we thank everyone to be a part of this panel discussion. I thank David sir, Srinath sir, Girish Gowda sir, Dr. Ibrahim sir, Dr. Deepika Rane Patil, Dr. Santosh Mangshetty sir, Dr. Bashir sir, Dr. Zama ma'am. I thank all the participants who are present here and they have been listening to our discussion with lots of patience. I thank everyone. I hand over the mic to Irfan.
Thank you, sir. I extend my heartfelt appreciation to each panelist for sharing their expertise and experiences, fostering a space for meaningful dialogues in the near future. Thank you, sir. Okay, so as we draw curtains on this enlightening conference on oromaxillofacial surgery, the present and the future, I stand before on behalf of the organizing committee with a heart full of gratitude and admiration for the wealth of knowledge and inspiration shared during these remarkable lectures. This conference has been a testament to the power of collaboration and the pursuit of excellence in the field of oromaxillofacial surgery. We have had the privilege of witnessing groundbreaking advancements, innovative techniques, and insightful research that have enriched our understanding of the specialized branch of medicine. Throughout this journey, we have explored the progress made in oromaxillofacial surgery, from its humble beginnings to the cutting-edge procedures and technologies that define the present. But what truly excites us is the vision of the future that emerged from our discussions. I extend my heartfelt gratitude to our distinguished speakers whose expertise and dedication have enriched our minds and killed our passion for this field. Thank you all. Hold on for 5 more minutes so you all can collect your certificates from the reception committee and also come up on the stage to click group pictures with your respective departments. And the last speech for the day, I know it's getting really long. It's a vote of thanks, which is very important. And I request Dr. Vikhar Ahmed sir, Assistant Professor of the Department of Dental from KBN, to please address the vote of thanks. A very short one.
Good evening to everyone, distinguished guests, esteemed speakers, participants, ladies and gentlemen. On behalf of the organizing committee, it is my privilege to propose a heartfelt word of thanks on the remarkable conference, Maxillofacial Surgery, the Present and the Future. To begin with the Holiness, Janab Dr. Sayyid Shah Khusro Hussaini Sahib, Sajjada Nashi Dargah Hazrat Khaja Bandanawaz Rahmatullah Alayh, His Excellency Chancellor of KBN, and I would like to extend my heartfelt gratitude to Janab Sayyid Muhammad Ali Al Hussaini Sahib, Honorable Pro-Chancellor KBN, Dr. Sayyid Mustafa Al Hussaini Sahib, Director of KBN, and I like to thank our Honorable Vice Chancellor Sir, Dr. Ali Raza Musvi Sir, Dr. Rukhsar Ma'am, Registrar, and our Dean Dr. Siddesh Shirwar Sir, and Dr. Siddhaling Chingti Sir, MS of KBNU, and all the Deans of Al-Badr College, HKI College, and ESI College, and all the HODs and faculty members. Our sincere gratitude goes to our esteemed speakers who are here to generously share their expertise, knowledge throughout the conference, and thanks to all the participants. Special note of appreciation goes to organizing committee, members, volunteers, and event staff, media and press. And I would like to thank each and everyone. Thank you.
Okay, for the tea lovers, there is tea arranged. So you all can have a cup or two of tea and take the bag and the certificate.